It was recording already.
Red is recording.
Right.
No, yeah.
Good
Well, the
morning,
hand is there.
everyone. Oh my goodness, no response. Is that him not working? All right, good morning, everyone.
Good morning.
Great. I am Michael Hogue. That's not the name that's on the program. Dean Crouch from the pharmacy school had a last-minute conflict and was unable to open the conference this morning. He'll be with us a little later today. I am the Associate Dean Designate of the Center for Faith and Health in the College of Health Sciences here at Sanford. And for those of you who have been around HEAL for many years, the HEAL Institute, beginning July the 1st, will reside within the Center for Faith and Health at the College of Health Sciences here at Sanford. And so we're excited that you're with us. We have a very packed program today on perhaps one of the hottest topics in the news. In fact, just the other day I was listening to one of the national news networks on my drive home from work on XM radio, and the topic, a segment, was the controversy with one major pharmaceutical company and the pricing increases that they had on a particular generic drug product in the last few months, and it was quite an interesting debate that I was hearing. So I think there's not any more timely of a topic that we could have picked than the one that we've picked today. So I hope you will enjoy it and you'll engage with our distinguished speakers. So to get us kicked off today, I want to introduce one of the HEAL Fellows, Dr. Leon Dewar, who is the William U. White Jr. Professor of Pediatrics in the Division of Pediatric Neurology at UAB and Children's of Alabama. So, Dr. Dewar.
Thank you. I'll keep this brief. When we were thinking about a topic for this year's conference and the issue of drug pricing came up, one of the people that I thought of would be David Kimberlin. You can read his qualifications and you can understand that as a leader in pediatric infectious disease, that he is someone who, like many of the healthcare providers in this audience, deals with drug pricing issues. And in particular, he had been involved with the Daraprim and testified before Congress. But when I asked him, I said, well, David, would you be willing to do this? We'd really like to have you give a talk. He said, well, I'll be happy to do it, but the real expert is April Yarborough. And so we have two people to start, and again, you can read about April from the summary. She is a pharmacist at UAB in the Division of Infectious Disease, and actually has become quite expert with respect to the impact that rising drug prices have had on clinical practice. So without further ado, I'll start with David, and we'll have both of them. Thank you.
Good morning. Thank you for the opportunity to be here with you this morning. My task is really just to kind of tee things up for April, because she has the interesting and challenging cases that we will work through over the course of the next hour or so as we really dive into this important issue. I do have a question though. Who all in the audience is a physician? Nurse? Social worker, pharmacist? Who in the last month has either written a prescription, provided a prescription, or received a prescription for a medication? Do you know how much it cost? How much did the medicine cost? Just give me a number.
$3.
Did the medicine cost $3, or did what you pay cost $3? What you paid. So that's how we think about it, right? At least that's how almost all of us think about it. That's how I think about it. If I'm going to get a prescription, I go to, Harbin Discount Pharmacy, I pay $15. I pay $105 for a 3-month supply. I pay this, I pay that. What does it really cost? What does it really cost? And I would posit that that one question is the main problem with most of our healthcare system right now. We've done better in terms of providing greater access. We still have a ways to go, but access seems to be less of an issue. Now it's cost. The Affordable Care Act focused on care. It really didn't focus, they sidestepped affordability. They did it for political reasons, and it got through. So, I mean, you got to argue, you can't, you know, they were successful, but they kicked that can down the road, and now we're down the road, and we've got to start thinking about what things cost. We have a finite amount of money to spend on health care in the United States of America. A finite amount. It's a very, very, very large finite amount, but it is by definition not infinite. So I suggest, and this is where a program like the HEAL program is so incredibly important, this is going to take a lot of conversation, and it's not just conversations within the medical field. This is a societal conversation that we need to have. Part of that conversation is where the cost of medicines come in. Part of that conversation is where do you want to invest the resources that you have, this very large yet finite amount of money that you have. Do you want to put it into childhood immunizations? I would argue yes. I'm a pediatric infectious disease person. We all, those of us that are old enough in this room, remember Haemophilus influenza type B. We remember measles. Some of us remember polio. These are things that don't happen anymore because of these vaccines. I suggest that is where we want to put our money. Do we want to put our money into, through Medicare, paying for my 80-year-old mother's knee replacement? Do we want to do that? People in my family live to be their mid to late 90s. That's one argument. Another argument is she's 80. You know, so where do you want to put the money? And that's something that we've not done. When we've tried before, it's raised, you know, ludicrous comments about death panels and all these other kinds of things. So hopefully now we can do it in a mature way. And I do think venues like this, taking a piece of that enormous pie that we've got to have a probably decade-long conversation about, I think that's where this really comes in. So what we're going to hear about is probably the easy stuff, the low-hanging fruit. We're going to hear about really egregious kinds of things, and it's going to get us mad, and we're going to be able to stand up, and we're going to be able to say, you know, that's wrong, and y'all know the ethics better than I do, the ethical foundations of why it's wrong, and that's all good. That's part of what we should be doing. The challenge, though, is where is, I mean, you can say that's egregious, that's extreme. What about that? What about that? What about that? As you back it down, when do you get to the point of finding yourself in a position where you are stifling innovation? You are setting in place restrictions that impede the free market that has developed these phenomenal drugs that we have right now. The opportunity to extend life, the opportunity, hepatitis C is the most miraculous one in decades. Hep C is the leading cause of liver transplantation in the United States. And a lot of people have hepatitis C. And there was absolutely, and we didn't even know what it was until the 1980s. It used to be called non-A, non-B hepatitis because it wasn't hepatitis A and it wasn't hepatitis B, but we figured a lot of people had something out there. They figured out it was hep C. And with the new drugs, the second generation, now third and fourth generation of hep C drugs, we can cure it with 12 weeks of treatment. 12 weeks of treatment can cure hep C and prevent a patient from going on to need a liver transplant. That's amazing. Each pill, $1,000. Why? Because they can. Because they can. But it also cures. It cures. So $8,400, $1,000, something like that, treatment course can be curative. How do you deal with that? You say, well, they invested, they deserve it? Do you say, they invested, but that's too much money and we're going to cap it? Do you say the free market should take care of it? Which actually it is in that example. The prices are coming down. It's not taking care of it completely, but they're coming down. So how do those newer drugs, the new developments, those I think I would suggest are a little bit harder than some of the older drugs that we're going to be talking about. So our objectives today are to think not only to use these extreme examples as the context, the lens, if you will, through which we look at this bigger issue, this bigger challenge of drug pricing. And we got to think about what the consequences of doing X or doing Y about it would be. Would it slap down what I consider to be the crooks that are doing some of these egregious things? Is that good? That'll feel good. I'd feel good with that. But then you have the unintended downstream effects as any kind of a relatively large hammer of a legislative approach to anything always has the unintended consequences. How do you balance that? So we're going to be talking about things at the individual level. We're going to be talking about, and that's where April's so good about, because she is the one that interfaces with the pharma companies or with the distribution pharmacies to try to get a medicine for a patient who needs it. You don't get any more individual than that. But we're also going to be talking about it on the second bullet in societal language, its societal implications, and societal terms. Again, using these very extreme examples and thinking about whether, how, and when additional remedies should be put in place when the market seems to be failing. And these are some of the headlines of how the market has failed, or at least at the current time is failing. And you can see this guy, Martin Schlechte, or whatever his last name is, that probably is who was on NPR. He's usually the poster child, which he seems to get. I think this is from his congressional testimony before, when he was taking the fifth before Congress, and his lawyers finally got him to take the fifth and shut up, which they were just hating everything he did on these live streams on the internet and stuff, and just not quite right in the head. But he's having a really good time there as he's getting grilled by Congress. He doesn't realize that that's probably not a good position to be in. He thinks it's great because he's getting the attention. So he's a former CEO of Turing. He soon will be probably in jail for securities fraud, not with Turing, but with a prior company. And he's about, 30 years old, 28 years old, something like that, 33 years old. So these things are getting everybody's attention. This is the reason the Special Committee on Aging for the U.S. Senate is looking into this particular aspect of drug pricing. This is the reason they had a pediatric infectious disease person testify before the Special Committee on Aging, which I found to be rather amusing and ironic that a pediatrician would be talking about aging, or at least before a committee focusing on aging. So we're going to look at it with these kinds of stats in our minds. In 2014, there was a 13% jump in drug pricing. We now spend more than $1/3 of $1 trillion, $1/3 of $1 trillion on drugs. And that includes the new drugs. I've mentioned the Hep C drugs. We can talk about cancer and the rheum drugs as well that you see on the TV, which are odd. Those direct-to-consumer ads are odd because there can't be that many patients with rheumatoid arthritis. Yet they are on every 20 minutes or so on the ads. There's got to be a reason that's beneficial for the company. They're not stupid. They wouldn't do it unless there was a return on investment. And their drugs cost a whole lot. The new cancer drugs, some of them $100,000 a course. But if you got the rare cancers that those treat, I'd try to pay for it. I'd try to find some way to pay for it if it was me, or certainly if it was my child. We have generic issues as well, generic equivalent products that have been on the market during the calendar year 2014, which normally would lead to a decreased price in a typical market where generics come on, now actually have an 80 to 85% where they should have a decrease, but they're actually having, in some cases, an increase. In 2015, we're back up in double digits again with respect to the drug costs. So what we don't know is whether this is a new baseline for us, or is the market out of whack to such an extent that it's just not working anymore? And if so, what do we do about it? Or is this an aberration and we should just ride through it and let the press and the shamefulness lead to the kinds of adjustments that are necessary? And if you get down more granular and you look at the branded drugs versus the generic drugs, and this is where I was thinking these data would come in, about 15% increase in the expenditures or the costs of the branded drugs, about a 9% increase in some of the specialty drugs, a 3% increase in generics, even though typically generics should drop prices by huge amounts because they're generics. Whether or not, you hear, and we may hear, I think, from a farmer representative, or former farmer representative, the trade organization Pharma, a lot of the pharmaceutical companies say, look, it takes $1 billion to bring a drug to market, and most drugs that are in development don't make it to market, so that we got to make up these costs. It's a legitimate point. Are they using it correctly and they're accurate, that every bit of the dollars that are going into these new drugs for new drug development are going toward R&D? I don't know. Are they using that as an excuse to crack up and get as much profit as they can? Their shareholders certainly expect that of them. That's the way our system works. And again, are we at a point where we need to be doing something to address these rising costs? So this balance is patient access and well-being with existing drugs, with new drugs. The existing drugs are new to the market or they're very old to the market. I'm going to turn it over to April now, and she's going to walk us through some examples that I think will help frame the way that we're thinking about this and frame the structure of the debate. And we will have time, I believe, at the end for a significant amount of interaction, because this is not a one-way deliverance of information. This is where the dialogue has to begin. April.
Okay, so I'm really just going to talk about more of getting you guys in the mindset of thinking about, well, Martin, the touring CEO, his biggest argument is one of the things that David said was, we need it for research and development, but the other big argument that we heard a lot in trying to take and get acquisition of Daraprim for a patient was, well, patients don't suffer. The drug is always available. Somebody's picking up the cost, but it's not the patients. The patients are not impacted by these drug costs, which I have several cases here, and they're not all pediatrics and they're not all infectious disease, so you guys bear with me. They're kind of across lots of spectrum. I would argue that that's actually not the case, and I have cases here. Interesting enough, these are some of the examples of, and these are really not necessarily the outliers, but these are the ones that I think that have made the most national attention recently. So on top, you can't have any talk about pricing without talking about Daraprim, which was the touring drug. And it had roughly, over the last couple of years, a 5,000% increase. Another drug was Aquasol, which is vitamin A, which is a drug that is recommended in preterm babies to help prevent, to help basically regenerate lung growth. Isoprel, which is a cardiac drug that's really important in cardiac intensive care units, cardiac surgeries, emergency rooms, anything like that. Nitropres, again, is another cardiac drug. These are adult drugs. Actar, which has had a 13% increase. Sildenafil, and this is not necessarily talking about Viagra for erectile dysfunction. This is actually talking about a drug that is used for primary pulmonary hypertension, which is a lethal disease. Albendazole, which is, we will talk about in more detail. Again, another 5,000% increase, which is interesting because when we talk about the case, you'll kind of wonder why this didn't make national attention and more media attention as well, because it's had roughly the same increase in price. And then probably really concerning is I have some friends in the toxicology realm of medicine, and this was just something that was so shocking to me. So these are some of the more common antidotes down at the bottom. So things such as lead poisoning, Coumadin overdoses, Coumadin or warfarin, so mercury poisoning, so things like that. Again, lead poisoning's made the news recently, but these are 6,000% increase. This top drug right here, 6,000% increase in the price of the primary antidote for lead poisoning. So, and then interesting, we talk about these big numbers, we're in the thousands as far as percentage increase, but I think this is pretty sad, just talking about practicality for patients. So someone needs to go get an EpiPen because they're having anaphylaxis. It went from about, you see it's over $300 for an EpiPen now, so an uninsured patient may go without one simply because they can no longer afford it. All right, so let's get into some cases. So, no surprise to you guys that David and I are going to pick a case involving Daraprim as our first case. But, so I'll kind of preface a lot of these cases into saying nothing related to HIPAA will be violated here, but these are all real patients that were either seen here in Birmingham by some institution or a hospital here, except for one, and there's one that was still in the state of Alabama that we actually acquired, so these are all real patients that I know, these are not made-up cases. So the first one is a 30-year-old pregnant woman. She was found to be diagnosed, confirmed for acute toxo. You guys heard a lot of it. She's scheduled for delivery, baby was born, no complications. Standard of care would be the following. So, in a perfect day in healthcare, this mother would have gotten Daraprim, sulfadizine, and leucovorin, right? Also, we work up the infant, we initiate the therapy with essentially the same 3 drugs, and then we finish all our testing. However, the kicker is, this adult patient, Daraprim is no longer available at their hospital pharmacy because the price of the drug is $750 a tablet. Also, it has to be acquired through a specialty pharmacy as an outpatient. So even if you could acquire the drug for an inpatient patient, once they go home, it has to be acquired only by a specialty pharmacy. And then complicate that to the fact that at the time of this patient, the specialty pharmacy couldn't formulate a dosage form that you could give to the baby. So it was like, well, we can give you tablets, but we can't actually put it into any sort of dose that you can give to a child. All right, so thinking about that, medication was unavailable to the mother. The $750 a tablet, $90,000 a month for her dose alone. The mother then complicated the situation. I mean, these are real patients. You guys know this, no matter what avenue in healthcare you work in. She was undocumented. No patient assistance programs were available to her at all because she was not a U.S. citizen. The physician taking care of the mother then decides to start, Bactrim therapy, which is considered second line, but a lot of people in the tox arena would argue that it's not as effective. So then comes, I like to say my shining glory is that then we were able to actually get the drug for the baby simply because there was actually leftover medication in our outpatient dispensing pharmacy in our hospital. Really the only reason the patient got their medication. We compounded it, we sent in, and everything was treated. Patient was according to ARPA. Mom was treated with a second-line agent. Baby was treated with standard of care. So at the end of every case, the thing that I want us to think about is, did drug cost, in this particular case, contribute to an adverse event in the patient? Anybody? So I think you could argue probably either way. Mom was treated with a second-line agent. She's doing well. Baby actually was able to get the drug, so potentially not. This was a lucky case. I've had 2 others since then. And why is this important? So probably out of order, but pregnant women who acquire toxo have 25% risk to transmitting it to their baby. It is fatal. Congenital toxo babies, unfortunately, are usually asymptomatic in about 90% of the cases, but can have anywhere from just mild vision and hearing loss all the way up to major learning disabilities within the last several years after diagnosis. But I think this last bullet point is what the take-home point is. To treat a child with congenital toxoplasmosis is up to a year, and it costs roughly $700,000 to $750,000 for the one drug alone. All right, so second case. 5-year-old autistic child presents with abdominal pain, irritability, and increasing behavior and self-mutilating behavior. So we get an x-ray in the ED, and it shows that they have multiple opacities in their intestines. So mom then reports through history that the child has been biting on their staircase. They live in a 100-year-old house, so someone thinks, well, we should probably check for lead toxicity. And sure enough, I put all the normals in here. Less than 5 is considered to not have lead poisoning, and this child's was pretty much 100. So they're now being diagnosed with lead toxicity. So going back to that first slide talking about antidotes, well, the primary treatment of choice would be this calcium sodium, the EDTA. However, the hospital has none, can't get any, can't order it, it's way too expensive. They actually call all of the hospitals in the health system related to roughly 150, and I think it was actually around 200 miles in the perimeter. No one has it, they stopped stocking it because of the cost. This child ultimately transfers to Children's, but total cost for a 5-day treatment is about $140,000 to $150,000 for just that drug. So lead toxicity, again, has made the news recently, defined as a blood level greater than 5. Treatment with the antidote, typically there are multiple antidotes that work in combination to treat the lead levels, but lead poisoning is important because you see what the symptoms are of lead poisoning, so you can have neurodevelopment delay, reproductive issues, seizure, coma, and death. So this is not something that we just ignore when we don't have the correct drugs. So what happens to the patient now? So they're sitting in an emergency room, this is before their transfer, and there's no antidote for lead poisoning, and their lead level is supposed to be less than 5, and it's 100, so it's 20 times the normal. So there are some alternatives, and they called our toxicologist on call and said, you can try this drug that's oral, and luckily they were able to get it from an adult hospital about 15 miles away. Well, it's not very well tolerated, especially in children. So the patient only tolerates 2 doses, and they need about 8 doses to get their lead level back down. Also, to complicate it, it develops this severe rash, low white blood cells, so then the physicians are stuck thinking, what do we do now? So there's another drug called penicillamine that they can give, however, it likely causes lots of, hematuria, more leukopenia, and the patient already has a low blood count. And that drug by itself also cost almost $17,000. So this patient was ultimately transferred to Children's and was able to get the appropriate therapy, but did the drug cost contribute to a patient's adverse event? Right, that's a pretty obvious one. Because even if we argue in the end the child received the correct drug, the thing is he had lots of suboptimal therapies up until that point, and we actually don't know, for the purposes of this document, we don't know if he has long-term sequelae from having lead toxicity for several days. All right, so I told you they weren't all pediatrics, and they aren't all infectious disease. So this is a 78-year-old uninsured man, started on warfarin therapy for a stroke, so very common patient in the state of Alabama and in the city of Birmingham. So he comes to his monthly lab visits to get his INR checked, which is what they check if you are on warfarin therapy. So reports 2 weeks of dizziness, headache, fatigue, as well as some increased confusion and bruising. And I know there's probably a lot of people just squirming in their chairs right now because you immediately probably know what the outcome of all of this is. No other symptoms, specifically ask if he's having bleeding and no symptoms of bleeding. So gets an INR checked and it's greater than 10. So our target is 2 to 3, so problem. Patient is then given a dose of vitamin K by an injection, which is the appropriate therapy, and told, don't take any more of your warfarin, return to the lab in a couple of days, we'll recheck it. Obviously, if you have any symptoms, come back. So it comes back 24 hours later because he's just not feeling well. Has the same symptoms, no improvement, and reports that his INR is still greater than 8. Again, looking for a 2 to 3. So you'll see on the next slide with the guidelines, he's given a prescription for some oral vitamin K. Seems simple enough, pretty routine. Fill it at your local pharmacy, take it for a couple of days, come back, we'll see you back. Obviously, any issues, let us know. Just so you guys know, they followed all the correct procedures. And outside of having active bleeding, you give a dose of parenteral or injection vitamin K for one number. If it's another number with no bleeding, you give some oral, and then just looking at it. So the interesting thing is down here at the bottom. So vitamin K prior to 2014 was available to uninsured patients for about anywhere between $1 to $3 a dose. So Valiant Pharmaceuticals has kind of fallen under the radar, I feel, but they're right up there with Turing as far as it was acquired. Valiant Pharmaceuticals acquired vitamin K tablets in 2015, and the price per tablet rose to $60. Right, so we're not talking about every drug in this presentation is not about $750 a tablet. We're talking about $60. We go back and think about our patient, elderly, uninsured patient, limited income. So anywhere from $1 to $2 to $60 a tablet. Call that pretty much just as bad. So fast forward 24 to 48 hours, you've got another patient, the same patient comes to the emergency room. This is where probably most of you know where this is going. Reports going to the pharmacy to pick up his tablets that he was supposed to. However, it cost $120 for his prescription. He doesn't have $120, most patients don't have $120. So he didn't fill it. No resources to pay for it. There's no patient assistance programs that he was aware of or that were made to aware of him to get any vitamin K, so he just sat at home with an elevated INR. So CT immediately reveals a brain bleed, and considered this was basically the contributing source of all of his symptoms leading up to this. So he'd been complaining for 4 days, and that's what we get. So, another easy question. Did drug costs contribute to this patient's adverse event? Absolutely. So, a couple more. So, 28-year-old Hispanic female comes into the emergency room. New onset of seizures. They last anywhere between 20 to 30 minutes. No history of seizure disorder, so totally normal until she walked into the ER and said that she reported, or the husband reported having seizures for 30 minutes. Complained that she had a headache for a couple of days, but really no other symptoms. Woke up with another headache, and then essentially an hour later had this 30-minute seizure. Her MRI revealed that she had large lesions, and then had something that diagnosed as neurocystic sarcosis. So the patient is from Guatemala, but has been in the U.S. for approximately 3 months. So what is this infection? Essentially, it is a preventable brain infection caused by a pork tapeworm or a parasite. It does cause seizures and death if left untreated, so it is considered important and fatal. Considered a neglected parasitic infection by the CDC. So if you actually go and look at all the list of different things, this is actually one of those diseases that the CDC considers as we don't actually put a lot of research into. Latin America and southern parts of Africa are considered the most common regions that are affected. So this is where we get back to the drug of choice is albendazole or Albenza. Roughly costs about $250 a day to treat a patient for this. This is the drug of choice. Recommendations are 10 to 30 days depending on severity of symptoms. So go back and think about what we said. So Daraprim, I always go back to it because it's what's made the most media attention. 5,000% increase in price. This drug had about a 5,000% increase in price, which is what we're going to talk about in just a second. And the fact that it's considered a neglected parasitic infection. So this is the primary drug of choice for this particular type of infection. So somewhere there seems to be a disconnect in the fact that we know it's a neglected disease, but yet the drug that we treat it with is had a 5,000% increase. So these are all kind of crammed together, but I feel like all these points are important. So if you kind of walk through the process of this particular drug, 2010, GSK sold the rights of the drug. Probably not that big of a deal, right? That happens all the time. Well, in 2011, the only other therapeutic equivalent to treat this particular infection, and necessarily the equivalent anti-parasitic agent to the albendazole, well, the only manufacturer in the U.S. decided to stop making it. So now albendazole is the only anti-parasitic on the market. 2010, the price of the drug in the United States was about $6 a day. But if you looked at it anywhere overseas, Central South America, South Africa, where this disease is really prevalent, it still costs less than $1 a day. Okay, well, we're used to that, right? I mean, things they're a lot cheaper in South America. South Africa, where there's prevalence, $1 a day, $6 a day, not that huge. We see I could name 100 drugs if that's the case. By 2013, though, the price in the U.S. had increased to $120 a day, while the price internationally remains still less than $1 a day. And in some countries, it's actually an over-the-counter, meaning you just walk into the pharmacy, you ask for it, and they give it to you. So there's availability issues there too. And in 2014, according to the CDC, prescriptions for this particular drug in a 5-year span between 2008 and 2013 increased by 5,000%, which is an interesting percent because that's how much the drug price has actually gone over the last several years as well. But they primarily contributed to the fact that in 2011, there were no other alternatives, right? So you expect this from 2011 to now for this to go up exponentially. Interesting enough, there is no patient assistance program available for this medication. So we focus on that a lot because, in my realm of what I think of, I can talk about how wrong I think drug pricing is and how we should, but if I'm able to get the medication to the patients that need it, really ultimately that's the bottom line. I think that's, the bottom line of most healthcare providers. This has no patient assistance program available, meaning there's no help out there for patients. I did find, just because we've had several of these patients, that there are some pharmacies across the country, none that I can find in Alabama, that have these prescription drug cards that sometimes can help pay for things. However, most of those pharmacies have been instructed that you don't distribute those to non-U.S. citizens. So, again, would not have been very helpful to our patients.
April, that alternative agent, do you know if it was equally effective, and how did it compare the price? Was it second
It was the drug of choice.
It was the drug of choice.
Essentially, you
Okay.
could alternate either one.
Okay.
It was actually more readily available, and then it started declining, and this came to the market, so, yeah.
Could I ask, why did the number of prescriptions increase by 50-fold when the price increased by 50-fold?
Because of the lack of availability of the alternative agent. That's what the CDC says, that they are attributing the fact that the increase in the number of prescriptions went up so much because essentially in 2011, there were no longer two alternatives to give patients.
But that would imply that the alternative one had 96% of the market. So that when it disappeared, the number of prescriptions, it's very odd to have the number of prescriptions go up 50-fold. And particularly if just one alternative, there's something about the math, doesn't
The numbers are actually kind of surprising to me, but I will tell you, just because of the ineffectuous disease for a while, that the other drug was very inexpensive and readily available and generic and had been available for a long time. So it probably would not be surprising to me if 95% of the patients were treated with that. Because it's still the drug when we actually have these patients. People always ask, we're going to give them a bendazole, right? It's like, not since 2011. You're
So
not.
why did the cheap generics suddenly not become available?
That's always a good question. I ask that question almost every day when we go look for drugs. It's drugs that we've used forever that are no longer available, and that's probably a good question for this group.
Isn't it true that all the drugs that you're talking about have been around for a long time?
Yes.
So they're effectively generics anyway, right?
Or should be. Yes.
So who in this room is, I'm not going to ask it the other way around, who is younger than 62 years of age? Daraprim has existed your entire lives.
Oh, wow.
What was the price before Turing bought it?
$13.75.
A pill? $13.75 a pill. One day later, it was $750 a pill. What changed? Turing purchased it. That's it. Same drug, 62-year-old drug. And yet it goes up that much. Why? Because it can. Because they can.
April, do you know if mebendazole, the other agent, if the powder chemical is available to be compounded by pharmacists? Could one source of bypassing this product be for raw ingredient product to be compounded to bypass this?
We've not been able to find it in any form because with these, we've had children with this exact same case, and nobody wants to purchase this drug to keep it on their shelf. Because interesting enough, it comes in bottles. This is just a practicality thing. It comes in bottles of 2 pills. So for a disorder that you're going to treat for at least 10 days. So, I mean, not that that matters when we're talking about per day dosing and things like that, but the manufacturer distributes it in bottles of 2 pills. Like, sometimes I just can't wrap my head around things.
And your question was specifically albendazole, correct?
No,
Mebendazole,
the one that's
was
not
the,
been commercially
yeah, which was the
produced.
drug that was
So-
before this.
With Daraprim, there is an alternative manufacturer that where they're trying to bring that into the United States. That manufacturer, I believe, is from India. And I would argue that it's a workaround from the FDA's of the FDA. I don't know the quality of that chemical. I don't know that the powder that arrives from India in a shipment that could be compounded for Daraprim is the same as a commercially produced, product that, albeit costing, 5,000 times what it cost a year ago. At least I know the quality is the same. And so that has been brought up for the Daraprim issue as the solution to it. I think there are issues, ethical issues, of using something that maybe if it's made in China, what is it, in China they found with some of the medicines that it's spiked with some sort of plastic that is toxic to children. And I'm not saying Daraprim has that, but I don't know that it doesn't have that either. So simply bringing in a powder, at least from I think it's maybe a little different perspective from a pharmacist standpoint than a physician standpoint, but to me, I still have issues with it.
David, isn't there a little bit of a catch-22 here? I mean, on the one hand, a company makes a drug and then that company's drug becomes unsatisfactory because of the price. So part of the solution to that would be easy entry for other drugs made by other companies. And you just said that you're in favor of highly restrictive measures to keep drugs from other places out of here because of concerns about quality. And we also know that if generic drugs new generic drugs that could be made by a company in the U.S., I mean, there's a several-year process that it takes for that to happen. So is this entire problem not in part a result of highly restrictive measures to keep generics from easily being made?
Too much regulation, in other words.
Correct.
First and foremost, the Food and Drug Administration's mission or mandate is not to bring drugs to market that cure disease. First and foremost, their mandate is to bring drugs to market that are safe. Safety is their primary focus. And they balance that with the need or the desire to bring efficacious treatments to market as well. But safety is their primary governmental mandate. And where I was coming from with the comment about the powder from India is I don't know what the safety of that is. Now, if it can be proven to be safe, that's fine, but probably that's going to take inspections of the plant where it's made. It's going to take quality control measures. It's going to take making sure I'm making this up, that the shipping temperatures don't go to extremes and so on and so forth. It's not simply calling up a friend over in India and saying, can you package up some of this and send it over to me? And so when you start down that road, eventually you end up with additional regulatory oversight, which raises the price.
Regulatory oversight, of course, is wonderful, but the FDA does inspect Indian plants that make generic drugs.
Yes.
And one would expect that the barriers to a new drug made by an Indian company that's respectable in the FDA's eyes would not be insuperable. And one would also wonder whether we need to have a 2-year process for an abbreviated new drug application here in the United States for companies to make new drugs like the ones that you've been talking about.
So an accelerated pathway for bringing a new generic on the market.
Right.
That certainly is, at the Special Committee on Aging panel, there was a person to my left who was a health economist from Johns Hopkins, and that was very much his point. And it resonated, I think, more with the Republican senators, but to some extent with the Democratic senators as well.
I think there's going to be some improvement fairly soon in the delay of getting a new drug through a new generic through the FDA, because recently they added user fees for generics, and so those user fees will go to hire more reviewers for generic drugs. And the expectation is that that will move the backlog through and accelerate the process for a new drug to get through. So that hopefully this sort of situation where regulatory delay is the issue would be a temporary situation that will work through.
So let me ask you, to follow that along, when the product has gone from $13.75 to $750 overnight, and a new generic is approved, where do you think it's going to be priced?
Closer to the price, the 700 for sure.
So there still is upward pressure. I think you're probably right. We're guessing. We don't know. It could be an altruistic thing where they want to bring it in and help the world. But if they're a publicly traded company or a company with stockholders, they're going to have people saying, well, can't we make a little money off this? And the overall pressure continues to increase. So the market may be the complete fix. The market may not fully address or even adequately address the pricing issues that we're facing right now. We don't know yet.
That's true, but we do know that for the great majority of generic drugs, once you get 3 or 4 players in the market, the prices come down to rock bottom. And so really the issue is, will there be enough potential competitors in these classes that are relatively small? And that is still an empirical issue, I think, because when it's a relatively small potential market, you don't get as many entrants. But once you get 4+, you do get competition.
So you're familiar with the black swan scenario. Everything's a white swan because that's all we've seen is a white swan. We've never seen a black swan. You may be right. I hope you are right. But it also could be that the economics of drug pricing are the white swan, and Turing and these other Valiants and others are the new black swan. And things have changed to a point where the market simply doesn't work anymore. And arguably hasn't worked for a long time because how much did our drug at the very beginning, how much did that prescription cost? It cost $3. No, it didn't. It probably cost $100. But it cost me $3. So my perspective on it has been skewed from the 1940s and 1950s when they linked insurance with job. And then it became a part of your benefit package, and there was a disconnect decades ago in what things really cost and what people are paying, and this could be seen at least to some extent as an extension of that. And you may be right. I hope you are right, but we don't know.
What I'm arguing is not applying to the on-patent drugs. It's really applying to the oral generics where you get multiple competitors. That market still seems to work. But I totally agree with you on many of the other segments of the market.
The other thing that these companies are doing, and I see your hand, so let me say one more thing. The other thing these companies are doing, very smart, they are going after old drugs, 62-year-old drugs as an example, that have the old idea would have been, hey, I want to buy a generic and increase the price. Let's get a generic that a lot of people prescribe. What these folks learned to do was counterintuitive to that. They said, hey, let's get a generic, a really old drug that only a few people need, and then we can really screw them and get it up. And that's what Martin emailed me. He said, I don't care about getting money from the patient. He emailed this to me. And I submitted to the Congress. I only want to get the money from the insurance companies. He wrote it. That's amazing. But the issue is that there are so few of those patients. Is there enough of a market force to come in? Well, there probably, you could argue, is now, since he disrupted the market so much. But will it come back in at $13.75, or will it come in at $650 or $550? And will you really end up with 4 or 5 manufacturers when you, how much would you say Daraprim, how many patients need Daraprim each year? I mean, it's in the hundreds of thousands. It's not in the tens of thousands or hundreds of thousands. I'm guessing. I'm not quite sure on that. But that was their brilliance. They focused in on something that was so narrow that it's unlikely to have, at least within any timely fashion, because of the regulatory processes to bring another generic online or available in the U.S., to have that kind of an impact.
That's the problem with the profit motive.
So that could be, on the other hand, yes, I hear what you're saying. On the other hand, the profit mode is what led to Hep C drugs. And if I have Hep C and I'm on the way to liver transplant and I can be treated and cured in 12 weeks, that's miraculous. It's the system we're in. Do we want to completely change the system? Can we tweak the system? Can we modify the regulatory oversight of the system? Those are the big questions. Yeah, you want to say.
Well, first I want to say to April, appreciate your bringing up these cases, which I'm not sure you're going to get through because so many complex issues have been raised. But clearly, these examples and most of the discussion so far has not been at all about high prices to pay for drugs that present a markedly better health improvement for the patients. Prices we're talking about are unrelated largely to health gain. They're simply raising, and they're just simply price gouging and ransom pricing. And then there's market spiral pricing, which is a pattern that an oncologist and I found with Express Scripts data, that companies raise the prices of previous drugs and current drugs across the market. So the whole market floor keeps rising in a spiral, and then new drugs will be priced above that rising spiral. That seems to be the de facto pricing mechanism that is evident in Express Scripts data. So I just want to signal, because there's no time to do it, that when you say why are prices going up because they can, is really to say, I'm not an economist, but is to say that means there is no viable buyer's market. The market is not working as a market of sellers and buyers, and we need a whole day or maybe a whole year to describe the distorted, quasi, and non-market, including market myths of the so-called American healthcare market, almost all of which does not exist in any other advanced capitalist country. It's the only advanced capitalist country that allows these kinds of things. It is illegal to raise the price on any previous drug in most countries. Even countries that allow the company to set its initial price as high as it wants, do not allow it to raise it after that. So Gleevec now costs 3 times more in the United States than it did originally in the United States. So because they can is to say because we have a so-called market with no organized buyers and highly organized sellers who use monopoly pricing to gouge patients and insurers.
So would allowing Medicare to negotiate drug prices, would that bring a new powerful buyer into the discussion? Am I hearing you correctly? I mean, they would end up as a buyer, correct?
If it's organized that way, that depends. The Veterans Administration does competitive pricing and bidding. First, they have independent, internal, fully salaried specialists decide how much added value a new drug can bring to VA patients, or they think it can. And then if they decide that the added value is worth putting the drug on at all, they then start competitive bidding. But most drugs don't add much value. Most new drugs are found by independent review bodies not to be clinically much better than existing drugs. These are review committees in several countries, so most new drugs don't add clinical value.
And correct me if I'm wrong, and I'm sure you all already realize as well, Medicare is not allowed by law, by Congress, to negotiate drug prices. VA is different. VA, I don't know why it's that way, but VA can. And it seems to work relatively well. But Medicare, Congress has a law in place that does not allow Medicare to negotiate. Yeah.
Hi, I'm Ray Smith from Pharma. So I know that this is organized as a series of presentations, and I don't want to keep you from getting through your presentation, because we seem to be turning into a broad discussion of all the issues. But just 2 points now, and I'll touch on these in my presentation later. One is, and we can debate this back and forth later. One is, I think the notion that there are no organized buyers in the United States is not accurate. There are 3 companies in the United States that buy 80% of all of the drugs in the United States, and cover 80% of the population. Express Scripts has a population bigger than Germany that is buying drugs for. And I'll go through the tools that they use and the kind of pressure that they put in the system. So that's number one. Number two, the law in Medicare actually reads that the Medicare Part D program is set up to have competing private plans which negotiate with manufacturers. the law says that the CMS administration cannot interfere in the negotiations that take place. Express Scripts, which negotiates on behalf of many Medicare plans, actually negotiates on behalf of a population that's twice as large as the entire population covered by Medicare. So I think that, the notion that there's no negotiation is also not quite right. If you look at what's happened with Medicare Part B premiums and how level they've been, people like Don Berwick, President Obama's previous CMS administrator, has said this is competition at work. That's what's holding the cost down. So I think we're kind of generalizing very, very broadly when in fact there's lots of other pieces going on that bear some attention.
Thank you.
Yeah. You're right, I stand corrected. But the question would be, where were the PBMs? Where are the PBMs when there are sudden price hikes in the drugs? If they are really large organized buyers working on behalf of employers, okay, how come they allow these things to happen?
Yeah. So are we gonna, do you want to go
Sure.
have the discussion now?
Except we do need to wrap this one up in the next 5 minutes.
All right, well, okay.
This is a good way. You don't need coffee in this room.
Look, the PBMs are out there putting a lot of downward pressure in the system. CVS, for instance, Caremark, the second largest PBM, buys for tens of millions of people, just reported that it held drug cost increases for the population that it covers in 2015 to 5%. Okay, and that's quite a bit different than I think the 18% or whatever that you showed. There is a huge amount of pressure. There are issues in this segment of the market that you've been focusing on. And let me make two things clear. Pharma has very publicly stated about Turing and Valiant and that kind of system, that these are hedge funds masquerading as pharma companies, and that there ought to be responses to it. I suspect, I'm not, I don't represent the PBMs. I suspect that what's happening here is we have markets that are so small that they haven't attracted as much attention. So, to the discussion earlier, we think that there ought to be initiatives to clear out the generic backlog, and that we ought to be looking at incentives to help deal with this problem of very small markets that can't attract generics, into it, leading to this kind of result.
If we want to finish up.
Okay, this is pretty much it. So, kind of taking that and thinking about not a small population of patients and drugs. I mean, I think anything that has to do with cardiovascular disease in the U.S. is probably much more on a larger global market, right? So these are just highlighting not necessarily cases of just general cardiac drugs that have had spikes. So you've got one drug that's used for urgent blood pressure management prior to 2014, cost less than $50 a vial, right? $50 a dose. Valiant, that company keeps coming up, and was bought them in 2014. And 2 years later, we're at $800 a vial. Same thing with an antiarrhythmic drug used for cardiogenic shock and heart failure. So again, these are widely used drugs in cardiovascular units, emergency rooms, things such as that. So about $100 a vial, and now we're up to $1,800 a vial. So the reason why these are important is these are very commonly used drugs in emergency rooms, crash and code carts, cardio units, cardiovascular surgery centers. And I know definitely, you can look at the numbers at the bottom, just talking about the Cleveland Clinic, which is really well known worldwide, reports that just being able to budget for these two drugs after this price increase changed their budgeting for the year by more than 10%. So this is 10% of their drug costs come from just stocking these two drugs. So that's pretty significant. And then UAB, just right here in Birmingham, reports a threefold increase in their budget estimates per year just to be able to keep these drugs in the crash carts, to be able to take care of their patients when they come through the emergency room. There's actually 2 hospitals in the city of Birmingham that no longer stock these in their crash carts in the emergency room because of the cost. So I think that's something interesting.
I believe our discussion basically, we jumped into that. I will say as we finish this in the next 15 seconds, I don't know what the answers are. But I think that in a relatively short period of time, a lot of the issues have been put on the table and respectfully argued across the room. I will say, 2 days ago, I was at the American Academy of Pediatrics, and I was speaking with the Executive Secretary of the Advisory Committee on Immunization Practices, ACIP, which is a CDC advisory body. And we were talking about pricing of new vaccines. And there's a very effective new vaccine that in the US costs several $100s a dose, and in the UK costs $16 a dose. And the reason is because the UK government said we're going to pay $16 a dose. And the manufacturer said, okay. And in the US, we don't have that. So then, should we? You know, think about that as y'all are moving through your very provocative day today. What are the downstream consequences of that? Will there be a lack of innovation if the profit potential is capped? Is it fair for the US to not have a cap on a drug price or a vaccine price and essentially subsidize the rest of the world that puts those caps on? Is that fair? Or is that what's happening? Arguably, you could say maybe that isn't what's happening, but to my non-economic mind, that's what it looks like to me. We let our prices go way up. Companies make very large amounts of money, and they make less money in other countries because they don't allow that. And then they develop great drugs that we benefit from. So honestly, you can hear me talking on multiple sides of this issue. I think if it was an easy issue, probably the HEAL conference wouldn't undertake it. That's, again, the beauty of what you guys do. And I appreciate very much, on behalf of April and myself, the opportunity to launch what I think is going to be a really provocative and intriguing day. Thank you very much.
So as we transition to break, I just want to acknowledge that in addition to the healthcare providers that David asked you to raise your hand, we also have members of hospital ethics committees here. We have members of the clergy. We also have congressional staffers here from Alabama's congressmen. So I just want you to be aware that there's a very broad audience here, and we're going to have a great dialogue as the day goes along. And lastly, in case you didn't see it, the American College of Clinical Pharmacy just put out a call this week for a special issue they're going to be doing in the journal Pharmacotherapy on drug pricing. So we're going to have a dialogue with our speakers today about potentially taking the proceedings of today's lectures and potentially putting those into a manuscript that we submit to that specific journal Pharmacotherapy. So I just want to point that out. We're going to take a break and try to get started back here at 9:45. So there's coffee, I think, and water out in the refreshment area, and the restrooms are down to the right.
Our next presenter, Dr. Donald Wright, is a distinguished sociologist who has, through his many publications and presentations, addressed important issues dealing with healthcare and justice, in particular drug pricing and the delivery of healthcare. His Doctor of Philosophy is in sociology from Brandeis University, as you read in the bio, and currently is Professor of Psychiatry and Comparative Health Policy at the Rowan University School of Osteopathic Medicine, and a guest researcher at the New York University Division of Medical Ethics. The title of his presentation is Pricing and Good Value Blocked by Biased or Unknown Effectiveness and Cost. Please welcome Dr. Donald White.
Thank you. It's very nice to be in Bulldog country, and I hope the team is doing well. I'm not tracking it, but that will be good. I gave a talk yesterday that it's beginning to sound like I should be giving today instead of this one, but there it is, because there was a much larger sort of societal view about research and development and the pricing of drugs for the whole system. But I will start in the same way, and I want to start by celebrating Edmund Pellegrino as founder of bioethics and trying to first establish a kind of common ethical grounding for the talk. He wrote in 1991, the Bulletin of the New York Academy of Medicine, "Medicine is a special moral enterprise grounded in a special personal relationship between the one who is ill and the other who professes to heal. To heal is to make whole again, to ameliorate the ways illness wounds the humanity of the one who is ill." And many years later, that the end of medicine is humanitas, a love of mankind. So this is the great physician and president of Catholic University, who's on our meeting today. His moral vision and compass was around the word to heal, based on the best medical science with compassion, which means to suffer with, to treat all who are ill or suffer. And one implication of that is that health care is a human right. When some of my ethical friends talk about health as a human right, I don't know what they're talking about. My nephew is diabetic, and does that mean he's been denied a human right? I don't think so. But health care as a human right is very widely embraced and in a number of national constitutions. And Trudeau Lemons, a distinguished professor of law, has written about that part of that human right is a right to having trustworthy knowledge, that doctors and patients need trustworthy knowledge. And the goal then is to develop clinically better medicines for patients and to minimize harm through adverse side effects. So what would developing pharmaceuticals for a whole society like this look like? Well, one would start with some systematic undertaking to estimate the disease burdens amenable to drugs and vaccines. And that kind of exercise is done by the World Health Organization in a publication that they keep revising every several years called Priority Medicines for Europe and the World. And I recommend it to you if you want to get an idea of how a whole society would think about, well, what kinds of drugs do we need? There's also an American partner to that at the University of Washington in Seattle. And then one would have public funding. After all, medicines are a societal need to treat patients who need help. Like the National Institutes of Health, which was founded as a major, actually unprecedented in size and scope, public undertaking to research for better medicines and treatment and to find effective treatments. And actually NIH uses some of this disease burden methodology in its own priority setting. And then to have publicly funded unbiased trials. You can have RFPs for trials which exist in some parts of the world to test for clinical benefits and harms, to see the degree to which what appear to be promising drug candidates prove out to be clinically beneficial or harmful or both. And then finally to make drugs available to all who can benefit from them with little or no co-payments, because co-payments, as we are reading all the time in the papers, creates a very serious barrier to access. And I would maintain there's very clear evidence that access to healthcare in the United States is still a very real and sizable issue. Now instead what we have is rights-violating corporate-driven R&D, where for-profit companies choose the research priorities, not healthcare systems or society, based only on patentable agents. They never consider unpatentable agents, with the goal of maximizing profits for their shareholders. This contrasts to, for example, the model of the Mario Negri Institute for Pharmacological Research, which is a large 3-campus research institute in Italy that does things very differently. And we just published the first book on the Mario Negri Institute and the implications of the institute as a model for how this kind of research is done and can be done at a very high level of research quality. And then we now have conflict of interest testing. Why do we have companies testing their own products. They design trials quite logically and understandably to minimize evidence about adverse side effects and maximize evidence of harms. So there are 5 ethical concerns about medicines. First, there's a concern on which there's a very large literature, some of which is referred to in Good Pharma, but I have a lot more, including some with me, on biased trial designs that preclude clinically and scientifically valid outcomes. There was a review in The Lancet 2 years ago that concluded that 85% of all clinical trials in the world, about 160,000 trials, provide no useful information for clinicians by design, because the endpoints selected and the way the trials are designed cannot provide them. For instance, all placebo trials cannot tell a clinician how much better or worse that drug is than the other drugs already being used. And according to the ethics of the Declaration of Helsinki, such trials are unethical because they're denying in the control arm access to an effective medication. Hiding weak and negative results. Extensive literature on the hiding of weak and negative results and selective transparency. This has led to this great transparency push in the United States and even larger push in Europe called the ALL trials. And all they're asking for is actually the first step, which is show us the data about the clinical efficacy or risks of harms. And after you do that, then you can have to turn to the other problems. But even the very first step is being vigorously resisted by companies in Europe and the United States. And bit by bit, we're getting more and more trials. We have a national registry here, but the reports show the ways in which the companies are delaying getting the data there, and then submitting only part of the data, and so on, and submitting in forms that make it harder to analyze. And if you want to read about this, it's extensively published in the medical literature, particularly the BMJ and the Lancet, but also in JAMA and in the Journal of Medicine, and the Annals of Internal Medicine. And then there's another biasing which needs to be addressed when medical journal articles are written up, because companies hire ghost writers and ghost managers, known as publication planning companies, who then selectively take evidence submitted to the FDA and repackage it and sometimes alter the endpoints and change the statistical analyses for the articles that then get published, which is the medical evidence, the doubly biased medical evidence that you read as clinicians and that then get into the clinical guidelines. So the problem is very deep and extensive, and it means that there is continued reports of misleading information that gets straightened out. I can go to that longer, but I'll run out of time. And so patent-driven research for profits, really, these are government-protected market silos. So what patents do is privatize public goods and lead to maximizing prices. So what we were just hearing about and what we're here to talk about is a result of that. And it rewards inflated costs. And it makes more patents on minor variations the main object of R&D. So in a review of the last 15 years of new drugs, about 90 to 92% of all new drugs are judged by independent review bodies to offer few or no clinical advantages, but they all get new patents, and then they all get heavily marketed. The 8 to 12% of new drugs that are clinically superior are often very beneficial, but some of them, like the one that was emphasized before I began speaking, Sovaldi, was discovered and developed with our money, NIH money, taxpayers' money, by researchers who were trained on NIH grants, and then the principal investigators incorporated, sold it, and then it becomes $1,000 a pill. So the $1,000 a pill was not funding private original breakthrough R&D. On the contrary. So here's a summary of 10 years of evidence for 980 new drugs. 918 are clinically minor. There's 2 breakthroughs, 13 with a real advance, and that's the large picture that is behind this pricing question, and leads to a very different way of thinking about it. And there's a conflict of interest of companies testing their own products, and naturally they want to have their trials help get their drugs approved so they can sell them. So they naturally have a number of ways, all of which are detailed in the literature also, for designing trials and selecting pet populations with many exclusions in order to increase the chances that they will have significant benefits to present to the FDA. They exclude those who are most likely to have adverse reactions. They use substitute or surrogate outcome endpoints very often that are not firmly established as equivalents. And they use non-inferiority or placebo designs. I need some water from somebody. Good, thanks. I'm not very particular, but any water will do. So there was a very nice detailed study comparing all the results submitted to the FDA with the same results published in the journal articles you read. And the team found that about 30% of the endpoints had been switched and the statistical analyses had been changed, which is this double bias that I mentioned to you. And the probability that negative results will be published is about 1/5 as likely as positive results. And then positive results get published more than once. So then when you end up doing, thank you very much, doing an analysis for clinical guidelines, you have a 10-to-1 ratio that's built into the published literature. Thank you, that was good. So to me, the interesting question is, why do we trust companies to do this? Now, we don't trust tobacco companies to do research on how healthy cigarettes were. We understand that tobacco companies are going to hire researchers and retain research teams at major universities to come up with the results that they need to sell more cigarettes. We understand when we had the big headline 2 weeks ago about the NFL evaluation of concussions, that, well, of course the NFL is going to downplay the terrible long-term effects of concussions. So why would we expect drug companies to do otherwise? And then companies also fund the regulators. So starting in 1992, Congress, in its wisdom, surrounded by the way, a Congress of lobbyists that's twice the size of the U.S. Congress. So you have the huge Congress of pharmaceutical lobbyists, and then we have the representatives of the American people and their senators. And anyway, each company pays large fees to that part of the FDA that reviews its drugs. So they're paying the reviewers' salaries to review their drugs. And this has steadily, and this is nicely tracked by Aaron Kesselheim at Harvard, steadily expanded the number of categories for accelerated reviews with less and less evidence of either efficacy or safety. It was mentioned that safety is the primary concern of the FDA, and historically that was true, but only 10% of the staff is now assigned to safety issues. 90% of the adverse drug reaction reports from companies come from drug companies, and there's a slow processing of those. There's a large backlog, and there's a new GAO report which concludes that the FDA is weak on safety, that it lacks reliable and accessible evidence on safety, it lacks leadership and resources, and that's just a matter of budget priorities. The priority of the FDA, funded by the companies it responds to, is to get as many new drugs through as quickly as possible, and the rhetoric is that these are life-saving. But they're mostly not life-saving, so you may know this famous article by 100 oncologists about the very high prices of oncology drugs, which concluded, as others have, that 90% of the new cancer drugs provide few or no additional clinical benefits, just like the rest of the larger population of drugs. And yet the prices are going from $100,000 to $120,000 to $150,000. And so they were expressing their concern, and also that their patients who are being made to pay 20% copays by the insurers can't afford them, and they're threatening their household budgets. That also is not allowed in any other advanced capitalist country, that you have, you allow companies to basically offload their responsibility as strong buyers by making the patients pay 20% of $100,000 or $120,000. And you know, patent holding companies define what safe means and what effective means. So they select their own endpoints. They're not selected by anyone who's concerned about health care or by that original suggestion that I made of a societal set of priorities. They're set by the companies, and this is the reason why in a review in the Archives of Internal Medicine, it was found that 1 out of every 5 new drugs ends up causing serious enough adverse side effects to lead to a black box warning or withdrawal. And amongst those with accelerated reviews, it's 1 in 3. Now those are enormous percentages of risk that are not the primary focus of the FDA, which is focused on getting as many of these so-called life-saving drugs to you and your loved ones as quickly as possible. So prescription drugs have been found to be the 4th leading cause of death. About 130,000 deaths a year, and the major review by an expert on drug trialing in Europe and Denmark says it's even larger, but I'll stay with a smaller figure. And someone asked me, well, so are drugs more dangerous than firearms? So I looked that up, and there are 33,000 deaths from firearms in 2014, and 11,000 homicides. So I think that answers that question. Drugs are also a major cause of hospitalizations, falls, and trucker accidents. About 2.7 million hospitalizations a year from serious adverse reactions from drugs that are approved as so-called safe and effective. And I've gone through this published medical knowledge being a second layer of bias, so I'll pass over that. Another conflict of interest is reflected in what is called the inverse benefit law. See, now yesterday I had all the materials for all of this. I thought, well, you all know all this already, but maybe you don't know some of it. And the inverse benefit law is that the more widely drugs are marketed, the more diluted become their benefits, because they get marketed to less and less serious cases. A nice example would be prescribing and marketing antipsychotics. So the testing is on people with psychoses, and now about 85–90% of all people being prescribed antipsychotics are not psychotic. Anyway, the more diluted become their benefits, but the more widespread become their risks of harm. They do not become diluted, and so that's the inverse benefit law of marketing. This is especially true for off-label promotion, which is done largely by retained physicians, because well, now it's maybe legal for companies to market for uses that are not approved, but largely it's been done by retaining doctors to talk to other doctors. Some of the techniques in this, described in this little article in the American Journal of Public Health, volume 101, page 399, include reducing the thresholds for diagnosis, reducing the thresholds for prescribing, creating new diseases and conditions. There's a lot of amusing fun around the new conditions and diseases that have been created. The one that's sort of amusing and fun now is female sexual disorder. Is it their disorder, and who's to say that the disorder is theirs? And encouraging unproven and off-label uses. Now, do huge R&D costs justify high prices? Well, first, about 84% of all funds for basic research come from public sources. And that comes from data from the National Science Foundation survey on R&D. But corporations control the end of the pipeline and the IP rights, and thereby control the rest of it. And that then creates all the kinds of distortions that we spent the first hour talking about. The net corporate R&D costs appear to be about 1/10 of the $2.6 billion figure. I can send you articles on any of these things, but this article is called Demythologizing the High R&D Costs. And let's see, very quickly, it's a non-random sample on a self-selected group of companies that submit secret data to their secret policy think tank. So the data are unverifiable, and we don't know how it was gathered. And then the analysis begins, and half of the total, 2.6 billion, is an estimate of the money they would have made if they hadn't started the research in the first place and put it into an investment fund at a high compounding multiple. But then if they didn't, can they really not do that if they're research-oriented companies? So anyway, half of it is, and then that's called the cost. So the profits they didn't make are part of the cost to you. And there are other interesting sort of inflators in the estimate, which is done by 3 famous health economists retained by the companies who've been doing this for years. And then the more recent literature on inversion indicates that such large profits are parked in overseas tax havens that the tax savings just from those alone may cover all of the R&D, in which case companies like Pfizer may actually have net of taxpayer subsidies, direct and indirect, no R&D cost. So let's turn to value-based pricing. Now in theory, it's a very clear argument. It's based on cost-effective analysis, and I just thought we'd start a little debate here by questioning, first of all, what the word cost means and what are the costs. This word cost implies, as a word, that there is some kind of a fixed thing or expense that you can't get around. But quite often the word cost is used when you're really referring to price. So, you know, if someone charged me $2 for this cup of water, and thank you for the free water, then my cost would be $2. But actually that was the price I paid for, and it could have been $4 or 50 cents. So the word cost has to be looked at carefully. And true costs are often kept secret and very hard to get at. So is the cost effectiveness ratio really the price effectiveness ratio that we call the cost? And the important point there is that that price is subject much more easily to being raised or lowered. And then there's extensive evidence that prices vary by 10-fold at least, if not 40-fold. So I was looking at the price of statins, and for a 30-pill month supply, they range from $595 to $7, and we just went through an hour of examples of the ways in which pricing can vary a lot. And so then if you do a cost-effective analysis before the 5,000% increase in the price, it looks very different than after it. So it seems to be often we really don't know either the cost or the price, and it's not stable in at least the American market for the reasons already discussed. Let's turn to the word effectiveness. So what does that mean for value-based pricing? Does it mean more qualities, which is, as you may know, an acronym for quality adjusted life years? What is it if clinical quality declines? So if effectiveness is qualities, and we're talking about an aging population where their health is steadily declining, or people with chronic conditions, how do we, is this the way to go? Is this way of thinking about price an ethical and societal way to think about price? And then there's a whole literature on how effectiveness varies by uses and by patients in different circumstances. So then, would you have various cost-effective calculations for different uses and different kinds of patients, which would imply different prices for the same product being used in different ways? And would some of those prices be, quote, wrong, and some of them be right? Then you have the company-controlled trial designs that lie behind value-based pricing, choosing surrogate endpoints that often do not measure real clinical outcome, minimizing evidence of harmful side effects, and so forth, which I've already discussed. And that's the evidence that goes into the calculation of effectiveness to calculate cost-effectiveness pricing. So there's sort of a triple-layered bias from the sellers. There's the randomized controlled trials that are often done on biased populations that have excluded people who are least likely to have complications, which includes some rather interesting groups. It often includes women. We all know women are more complicated than men, and so we need to exclude them, of course. And the elderly, and often children, and exclude people with more than one problem, so that a famous book called Bad Pharma, written by the physician writer in London, Ben Goldacre, talks about sort of freak populations on which RCTs are drawn. Sir Michael Rollins, founder of NICE and a very distinguished professor of clinical epidemiology, that the empirical basis for deciding value is still very weak. There are exclusion criteria, the absence of direct comparisons, poor measures of quality of life, and lack of external validity. And so if Sir Michael, whom I know and will be seeing in 2 weeks' time, comes to this kind of conclusion published, it makes me wonder how much confidence we should have in cost effectiveness analyses for value pricing. And he points out value requires special weightings outside of cost effectiveness analysis. Some of the ones he mentions are the severity of illness or suffering, the sort of added special import of prolonging end of life, and priority given to children and the poor. That is, there are other major ethical values that one needs to add in, and it's not clear just how to do that. So it seems to me what we need is a new paradigm, a research focused on real and serious needs, paid up from public competitive grants to which companies could apply, as well as universities and independent research institutes, so that you would have an independently based research model based on the societal needs the society wants, with transparent costs and real measures of clinical effectiveness. So an example of that is the Mario Negri Institute. So it makes the book important, and by the way, I get no royalties, and Palgrave is charging an outrageous price. So they're using copyright to do the same thing that drug companies are doing with patents, and I'm happy to tell them that. And it also kind of stifles intellectual discourse to have price gouging on books. Anyway, the Mario Negri Institute focuses on, that's what it looks like at dawn. That's the main building at dawn, about 5:30 a.m. Some of the features are that it's a not-for-profit independent research institute that does not patent its discoveries, has an open science model where all data and ideas are shared. They have several meetings a week where they brainstorm. It's a large multi-specialty, across all phases, integrated research team. And I found, by the way, 2 of those in the United States. They're both in NIH, where you have a fully integrated research team doing this kind of work, and dedicated to addressing serious medical needs. And the researchers keep control of what they investigate, how they do it. They control the data, the analysis, and publish the results across 51 laboratories and 3 campuses, and scientifically have a very high impact factor. So the question is, what can we learn from the principles and practices of the Good Farmer approach, a public health approach that is designed to have independent, uncommercialized research on real health needs of a population. And how can we reduce the epidemic of hospitalizations and deaths from prescription drugs and reform drug development to have good medicines at cost-plus prices. Thank you.
So, I guess, and I'm just not that familiar with this, how does the Mario Negri Institute fund itself? And another question is how would you account for, I'm not sure how to include somebody like the Bill and Melinda Gates Foundation, where they basically funded the malaria vaccine. How would you incorporate them into this model?
Yes, so the Mario Negri Institute works just the way that probably most of the research teams at the University of Alabama work. They're soft money, grant and contract-based researchers, but that means that you pay as you go. And in this case, they do full drug development, including trials. In making this short, I left out chapter 6 on trialing. So when they started doing trials, they decided trials are also a societal testing. And so they spent months organizing national networks of cardiologists and oncologists and dermatologists and so forth, and then had brought them together to think out the best trial design that would give the clearest clinically relevant answers. So then you have trials as a not-for-profit voluntary undertaking by a universal healthcare system specialists to find out the relative benefits and harms. And the trial designs are what are called comparative superiority trial designs. They only use hard clinical endpoints, not surrogate endpoints, and they're testing to see whether a drug is better. Now, I don't know about your neighbors, but my neighbors think that's what's happening now. They think when the FDA approves a drug, it's because it's better. I mean, why would the FDA approve a drug that's not better? But 90% of the time, it doesn't, and it does not require evidence of clinical superiority in these trials. If that one rule were changed, then about 80% of 160,000 trials would not be run, and we could save a huge amount of money that would Lancet writes about being wasted on pharmaceutical research that has no societal use. So I don't know if that answers your question, but it's grants and contracts, and I think what makes them unique is the ways in which they have figured out rules and practices that keep their research independent. Whether it's funded by pharmaceutical companies, which it is about 22% of the time, or by governmental sources, which is about 42% of the time, or by foundations, about 18% of the time. Yes?
Professor Light, I wonder how you would respond to the point about many drugs being produced, invented, and approved that are no better than other drugs that are already out there. The argument that phenomenon is actually a very beneficial one.
It is.
Because it provides competitors
to
the innovating drugs,
yes.
which actually eventually brings down the price.
Yes.
And secondly, could one not also argue that the problem is not with the FDA approving these drugs, but with public payers, in particular Medicare, which is not allowed to decide to pay for drugs based on cost effectiveness?
Yes.
Essentially decided that it's going to pay.
Yes. So it's hard to talk about this in the United States because we have almost none of the building blocks to achieve the original goals that I started off in the first few slides. But every other advanced capitalist country now has what's called a fourth hurdle, which is an independent or quasi-independent review body that reviews the relative added value of new drugs. If they don't think they have added value, they don't reimburse them. The companies can try to sell them privately on the cash market, but they will not be taxpayers' money will not be used to pay for drugs that are a little or no better. I thought the end of your sentence was going to be, it's useful to have nearly equivalent drugs because clinicians need choice, which they do, and because the profiles of similar drugs in the same class are sufficiently different so that it's useful to have more drugs in the class from a clinical and patient point of view. And the evidence shows that that is true up to about the third or fourth drug in a class, but by the time you get to the fourth, fifth, or sixth drug in a class, the relative clinical gain of having similar drugs is rather small. But that's not how you ended your sentence. Anyway, I hope I've answered your question. Sure.
I'm assuming that this process was developed in Italy. Are there other countries that use that?
Right. So I have not found very many models of the whole models, but there are sizable pieces you can find in the United States. So, for example, one of the pieces is the independent review by specialists of the relative efficacy of new drugs. So Kaiser does that, and they publish their results. They're on the web. And Kaiser decides which new drugs, and I've talked to people who do this work, that are being approved by the FDA or the EMA in Europe are sort of worth providing in their formulary. And then also deciding whether it should be first line or second line and whether they should be used in certain populations. So a really telling example is the Vioxx disaster, which is one of the worst disasters in modern drug history, occurred even though Merck's researchers, it's now all pretty well documented, knew well before the drug was even trialed that it had a much higher risk of cardiovascular trauma, but they went ahead anyway, and they found all kinds of ways of downplaying and manipulating the published results. There's a lovely, delicious literature around the ways in which they hoodwinked the New England Journal of Medicine, and then the New England Journal of Medicine had to backpedal on itself, but then they blamed Merck, but actually it was their own lack of astuteness, because there was an independent pharmacist who telephoned in the editor-in-chief of the New England Journal of Medicine saying, you know, you have missing data that I know of, and I think she was from Washington State calling in on a radio interview, and he dismissed her, and then within a year found that indeed the hoodwinking had taken place. Anyway, this is the kind of thing that you know we need to avoid and can be avoided.
One question.
Yes.
So, in discussing how funds are put toward research of new molecular entities, and you know this literature better than I, but I'm under the impression or understanding that the majority of new molecular entities are actually discovered by private researchers, typically university-based researchers, occasionally private companies, but usually university-based researchers, who are looking for new molecular entities that can treat novel diseases and so forth and so on. And then it's at a stage in the process when a new molecular entity appears promising, that then a pharmaceutical company may in fact purchase that entity from a university-based researcher and then take it the rest of the way home, so to speak, in terms of trials. So I guess that seems to me that perhaps there's a little bit of a disconnect in my mind, because my assumption would be that university researchers would have some degree of altruism, or at least that's been my observation in this town, to invest their time and effort and foundation monies in researching drugs that treat diseases for which there is not a treatment or an adequate treatment. So where is the breakdown happening? If the university researchers are spending their time on discovery of molecular entities that would in fact be breakthrough medicines, why does what is coming to market appear to be very different from what I think is happening? And maybe it's just that I think, and it may not be the reality, Is my question make sense?
Well, it does, but I want to address certain assumptions that are built in there. So one assumption is that an NME is going to be a breakthrough drug. In fact, even amongst the approved NMEs, about 40% of them are clinically not much better. So NMEs have a greater chance of being clinically superior in the end, but a lot of them don't. Then another assumption is around science and research. So Silvio Garatini, who's the founder of the Mario Negri Institute, likes to say we have wonderful scientific breakthroughs every quarter of every year, but few of them actually translate into better clinical care. And we feel very fortunate when a scientific breakthrough actually leads to clinical improvement. So you can have a lot of really bright, passionate scientists following really ingenious ideas and advancing science. That doesn't necessarily mean that it's going to improve clinical care. And I have a bias towards supporting those scientists. So I'm really delighted we have NIH, and I'm delighted that those scientists are there. But from the point of view where I started with the healthcare system and what the healthcare system needs, from their point of view, all that science is great, and one hopes that there will be clinical advances, but a lot of it may not be. And the final thought is that we are constantly bombarded, a lot of it by science writers that are part of a large network of pharma-supported and fed science writing, about how we're just on the brink of a revolution in medicine. And so if you look back, even over your lifetime, you can sort of count the number of revolutions in medicine that you've heard about that didn't pan out. So the Genome Project and the biotechnology, they're reviews of the number of real clinical advances against the rhetoric by people who write about the history of science and the sociology of science. So those are parts of an answer. And I think when the university researchers are doing their work, they can't know, and they usually don't know, with special exceptions like Sovaldi, that what they've discovered is going to be a major advance. It takes a little longer to find that out.
I think the concern of bias is a very real concern because, as you illustrated, it does affect the value of the drug and its effect upon people. The model that you suggest, I guess you could call it a non-profit research center. I guess assuming that it would not be as adversely affected by bias as the for-profit industry would. I work for a non-profit organization, this university, and part of the faculty, and I see bias all the time among us. I'm in a profession of scholars, and oftentimes bias determines what's published, what's accepted, what gets tenure, and so on. What is to keep a non-profit testing that determines the value of a product also free from bias?
Yes, well, I mean, that's a constant problem, for example, at NIH and NIH committees. And particularly since scientists do get so impassioned about their own pet ideas, they're sure they're the best. And then they may get one of their pals onto one of the review committees who helps back that. This may have nothing to do with medicine. So there certainly are those biases. And I think major features of the Mario Negri Institute is the open critical review of evidence and work across a number of disciplines. So if you are presenting your work at seminars, weekly seminars, and getting feedback from people who are trained in related parts of pharmacological research, and there's sort of open critical review all the time, plus other kinds of reviews like the reviewers for a scientific or medical journal. I think that helps control that. it's still, you're right, it's still a problem. I once upon a time thought that all academics were simply objective, people had no biases. I agree with you, that's not true. But if the knowledge is secret, if the testing is secret, if the patenting is designed to maximize the number of years of monopoly control, when you're doing R&D in that atmosphere, when the decisions to continue to fund or to drop a project are done by the vice president for research, that's profoundly different. So it seems to me, why not have the research for society's needs funded by society, with companies able to compete also? Companies, a number of companies have extraordinary resources and advantages over research teams, and I think would many times win the grants because they would turn in superior proposals with more resources to work with, like their data banks. But then to have for-profit companies involved in the manufacturing as they did earlier. So I don't know if you know that medicines were excluded from patenting for decades in most European countries. And for example, the AMA early in the 20th century opposed patenting. And again, we have a longer history of patenting medicines than Europe does. But the decades included periods of major advances. Now, for-profit companies were very much standing at the door to get licenses to then manufacture, sell, and make money. So it's not as if there would be a major role, but it would mean that we would recapture the societal need and the societal needs at the center of research rather than the maximizing of profits driving the research. It'll never happen.
So I'm curious to know what your thoughts are. For example, in many of your slides that show harm from medications, what is the contribution from off-label use?
Oh.
And is that something that needs to be regulated, in your opinion? I'm not advocating one way or the other, but what role do you think off-label use plays in this?
Yeah. Well, I mean, and you know, off-label is getting wider and wider, not just use, but legitimacy. Well, it seems to me it sort of undermines the whole purpose of the FDA. I mean, if doctors can prescribe any medicine for any condition, and sales people, sales reps as well as colleagues can advocate prescribing anything for anything, then why bother spending all this time and money going through an FDA review? And there actually are some serious proposals to change things so you would just do some short, relatively less expensive testing for early toxic reactions, and if they weren't there, just put all the drugs on the market and then start doing observational data gathering and see which things work better or not. So you could have, that would be a free market, right?
So to extend that a little bit, I practice in pediatric oncology, and we, I think, lull ourselves into some security that most of our patients are treated either on a study or according to a clinical trial through a research cooperative. And I think we think pharma doesn't have any influence in there because of the rules, regs, and everything, but I know there are lots of pharmaceutical industry-sponsored trials going on through that cooperative. But we often will have a patient who is not eligible for the study, but because the drug's commercially available, we feel free to go ahead and treat them according to the study. So we just get the drug outside of the study and treat them according to the protocol.
Yeah, so I should say a little bit more about that kind of quote off-label.
Yeah.
I don't like the term, it's too cute. It sounds like, is it your teenage daughter, son is trying to do something off record. You think they're at practice, but actually they're making out, something like that. it has a certain risque connotation to it. I think unauthorized has a more down-to-earth, serious, that appeals to my Puritan forebears. Well, off-label is too superficial a term. But anyway, so clinicians, especially specialists and especially oncologists, so my co-author is Hagot Kentarjian, professor of oncology at University of Texas and MD Anderson, emphasize how they're constantly experimenting and trying out new drugs and new combinations to see what might. And the key to that is the thing that you mentioned, which is the organized research cooperatives that track observational data. So if that's done in a responsible way, then it's adding to new knowledge. I think there's no advantage to society to then patent what's called a new use patent. But certainly that's going on all the time, and it should go on. But that's very different than the off-label marketing, on which there's a literature, especially around Randall Stafford at Stanford University, who's concluded about 85% of all off-label prescribing has no evidence of benefit, and bears all the risks upon that on-labeling label prescribing makes. So France, for example, does something we could do which would pertain to the earlier part of this discussion, and that is when new drugs come on the market, they initially have them prescribed in a number of leading healthcare centers like the University of Alabama, who are part of a regional and national data monitoring system to see how well the drugs work and to see what adverse side effects there are. We could do that. We could take FDA-approved drugs and first look at, watch them closely before making them available to everyone. Like you got yes.
Just a good example of off-label use. There are a bunch of drugs that were approved by the FDA for hypertension, and then later discovered to be beneficial for treating congestive heart failure. But they can't be marketed that way without going through the whole trial all over again.
Yes.
Which the drug company was unwilling to do.
Yeah, so I haven't thought that out, but what comes to mind is if you have a societal model, and the healthcare system and the society is funding new uses and promising new uses found, then there would be some committee meeting and funding of an appropriate trial to see that happen, or to put it through a regional monitoring observational system that you already had set up. Of course, all this is just fantasy, but that's what academics are supposed to do. They're supposed to think about better worlds that probably will never exist. Yes.
That process that you did sort of mention is going on currently because of all of the data that the electronic medical records are tracking,
yes,
even though they're not helpful to the doctor-patient relationship.
Yeah.
But they are producing lots and lots of data that are being poured into data banks and being analyzed to see what comes out,
Yeah.
and suggesting that could be a model for the future
Yes.
in terms of finding different disease processes that would be beneficial from a practical standpoint.
That sounds helpful. Yes, you, Virginia.
Yes, so I am a child and adolescent psychiatrist. And so I get stuck in the off-label trap. Or, I have to prescribe things off-label a lot of the time. Because the studies, I know there's a lot of older medications that are more effective, or that could be effective for my patient, but the studies aren't there, and no one's going to fund to go something that they can't put a new patent up on. And then I have a lot of mistrust of the studies that come out. Just many, I like to kind of wait and see before I start using something aggressively. So, I don't know, I was trying to say, like, off-label, it's that you're not using something that's FDA approved, but, the studies aren't there to back up and allow me to practice in that way. So.
Well, thank you for sharing that. Both parts of your statement are company dependent. And my question is, why do we want that to be company dependent on the relative profits from different lines of drugs that a given company is deciding to push or not push, and then switches when they do mergers and acquisitions? Why not have those problems discussed and then have the possibility of funding test and trialing by society?
Yeah, I agree with that. I mean, because what I'm left with is I have to make choices based on pathophysiology and weighing risk of harm and benefit and to help the patient that is from. So it's really tough.
So are child and adolescent mental health problems?
Yes. And if they get to me, it better be step 10, if we're looking at medications. So.
Thank you very much.
I'm very happy and honored to welcome Professor Patricia Danzel from the Wharton School of Business at the University of Pennsylvania here to the Hewlett Institute. You can read about her illustrious career. I'll say a little bit more about that at lunchtime. But for now, I'll just mention that she has studied healthcare in general and the pharmaceutical industry in particular for the last 25 years. And she is an international expert on pharmaceutical pricing. And perhaps it would be more accurate to say that she is the international expert on that topic, considered from the perspective of health economics. And I very much look forward to seeing what she has to say about pharmaceutical pricing.
Thank you very much, Tom, and thank you, everybody, for being here, and to the sponsors and the organizers for inviting me to be here. I have the unenviable task of talking about pharmaceutical pricing as an economist to a non-economics audience. So I'm going to do my best, and then there's Q&A at the end. So what I want to do in this talk is try and put pharmaceutical pricing in the context of really the pharmaceutical industry in its pricing strategies is not different from any other industry. But unlike most other industries, in the pharmaceutical industry, we have extensive insurance and third-party payment, and that changes everything. And so a lot of what we see happening in pharmaceutical pricing can be explained, I believe, by the structure of our reimbursement systems. And I want to look specifically at two categories of drugs in the US, pharmacy dispensed drugs and then the physician dispensed drugs, which includes a lot of the expensive biologics. And having talked about the status quo, I would like to speak briefly about my view of how value-based pricing may be a way forward. So first off, basic economics. You know, we do hear the pharma industry often rationalize high prices by talking about the high cost of R&D. And there is a relationship, but I would submit that it's not that prices are based on the cost of R&D or costs in total. That was not a profit maximizing strategy in the pharmaceutical industry or in any other industry. Prices are intended and designed to capture the value or the willingness to pay that exists in the market, and that is a way that in any industry a company maximizes profit. that to try to set prices to recoup the costs that have been incurred does not guarantee that the company will recoup those costs, because customers don't care what your costs were. What they're willing to pay depends on the value that they perceive in a product, and that's true in any industry. And so the sunk costs, the costs that have already been incurred, are irrelevant for pricing. But it is true that from an investment standpoint, the expected prices, which is an important part of the expected return on investment, does influence R&D. And so the causation runs rather from expected prices to willingness to invest, and there is that relationship in the marketplace. So as we influence pricing constraints in the sector, or lack of constraints, it will influence investment in R&D, and it makes that design of policy a complex decision. So in pharmaceuticals, as in any industry, producers design the product profile, and in the context of pharmaceuticals, that includes the design of the clinical trials, the decision about which indications to pursue, which specific molecules to pursue. So the product profile, the positioning of the product, the promotion of the product, all of that is designed to create a product that has value in the marketplace. And then based on customers' budget constraints, which includes their insurance coverage, there is a willingness to pay, and that determines what prices companies will charge. So that's sort of Econ 101 of pricing. Econ 201 recognizes that not everybody is the same. There is heterogeneity in the market, there is heterogeneity in the benefits drugs give to different customers. And so another consideration is what we call price elasticity of demand. And technically, by price elasticity, we simply mean the responsiveness of quantity sold to the percentage change in price. So if when a company raises price by 10%, the quantity demanded falls by more than 10%, that will not be a profit maximizing strategy, because you've raised price, but you've lost more on volume, and so that is counterproductive if you're trying to increase revenue. And so that is a situation in which demand is elastic, and it would not be rational to raise price. So there is this inverse relationship in markets where demand is price insensitive. Companies have incentives to charge high prices. And that's very intuitively obvious. I mean, we see it every day. When companies give discounts, they give discounts so that people use more. And they give discounts in markets where customers will be price sensitive. And this is true of pharmaceuticals too. Now, that's a basic principle, but of course, pharmaceutical price elasticity is very complex to measure and very multi-dimensional, because it depends not only on the number of close substitutes, the availability of clinical alternatives, but also on how payers structure their reimbursement, how much of the total cost of a product, the total price, is paid by consumers as out-of-pocket costs, cost sharing, whether physicians have any financial risk in the decisions. And in the case of the generic market, it's actually the pharmacists that make decisions as between substitutable generics. And so it's the pharmacy's price sensitivity that matters. So when we talk about price sensitivity in the pharma market, it's not just one group of customers, but we have to consider all the customers that may be affected. So this, I hope, takes some of you back to your Econ 101 classes. What I'm showing here is a picture of the effect of insurance on demand for drugs and on prices. And if you don't get the picture, it doesn't matter. I will talk to the intuition, I hope, in a clear way. Basically, what I'm showing here, this lower line called demand with no insurance, shows the number of units of this let's call it a drug, that would be purchased at different prices and makes the assumption that at higher prices, less volume will be sold. And in this market, I've drawn in a marginal cost curve and a marginal revenue curve. Don't worry about those, but take my word for it, if you will, that the profit maximizing price when consumers have no insurance is P1. And the quantity Q1 is sold, that's the point at which marginal revenue is equal to marginal cost, which you may remember from your econ class. Now give this group of consumers insurance coverage with a 50% co-insurance, meaning that the consumers pay 50% of the price. How does that affect the demand curve and the pricing incentives facing the manufacturer? Well, I've drawn in what is the pivot in the demand curve that results from this introduction of insurance with 50% co-insurance. At a price of 0, there's no change. But for every other quantity, the price that the manufacturer can charge is now twice as high because the consumer is only paying 50% of the price. Okay? So if the payer is totally passive, for any quantity sold, the manufacturer can charge twice as much. And that is why that blue demand curve is constructed so for any point on the horizontal axis, the height on the vertical axis is twice as high. That's what that's showing. And with this new situation, the manufacturer's profit maximizing price is P2, which is almost twice as high. But the manufacturer's profit maximizing strategy is to take advantage of this less elastic, less price sensitive demand by raising price almost twice as much, but also taking some increase in quantity. Okay? Is that all fairly intuitively obvious?
When you say it. When you say it.
Okay. Yeah. So, but I mean, the point that when consumers are only paying a fraction of the price, if consumer price sensitivity is the only thing controlling prices, manufacturers can charge higher prices. We're all familiar with the effect of insurance, that when people have insurance, they use more, that quantity effect. This is in addition to the quantity effect. This is the effect on the manufacturer's incentive to set the price. Now, being aware of this, payers in many situations do limit this effect and limit what the manufacturers can charge. But as a society, we are in this difficult situation that consumers want insurance. We as patients want financial protection against the cost of medical care. But it does have the effect of making us much less price conscious. And therefore, we need the payers to be some sort of surrogate to act as a cost controlling effect if we want to prevent this increase in price as well as an increase in quantity. Now, this is a pretty, by our standards, this is a pretty stingy insurance program, right? 50% co-insurance is pretty stingy, and yet price has gone up almost to double. With most of our insurance plans, we typically have a co-payment that is a fixed amount, and it may be $50, it may be $60, $100 per prescription, our cost-sharing amount. And then, as was said in the first talk, we don't know what the payer is having to pay. And we are indifferent to that, because what we know is our cost sharing. And so the question is, how does insurance influence the pricing strategies of manufacturers? And there is a real difference between how we handle it in the US and how most other countries deal with insurance influenced situations. And I will talk in more detail about our approach in the US, which has been to allow free pricing, to have the payers and pharmacy benefit managers that try to negotiate discounts using patient cost sharing, and I'll talk more about that. But basically, as has already been said, in other countries, the payer evaluates the price and decides what price they will pay. And one of the techniques that they use is to look at the effectiveness of the new drug relative to existing drugs. And if there is no increment in effectiveness, then they will simply pay the price of the existing drug. It's not that they will not reimburse it, but you won't get a premium price if there is no incremental effectiveness. But if there is incremental effectiveness, then there will be some price premium given. And that's generally the approach. There are other rules used, but that's the general approach. So in the US, everything is complicated. The way that we set the reimbursement rules depends on where the drugs are dispensed. And so that depends on the type of formulation. So oral drugs, which are obviously most of our drugs, creams, self-injectables, are handled through outpatient pharmacy. They are covered by the patient's pharmacy benefit if it's private insurance, or Medicare Part D if it's a patient on Medicare. And in that situation, we have pharmacy benefit managers that use tiered formularies and access controls like prior authorization. And I'll talk more about that. If it's a physician-dispensed drug, which includes many of the biologics, the infusions, vaccines, those are covered under the medical benefit, under Medicare Part B, and there it's a different reimbursement rule. The physicians typically buy those drugs and then are reimbursed directly by the third-party payer, so it's the buy and bill environment, where the reimbursement rule is average sales price plus 6%. So those are the two cases I'll talk about. There is a third context in the US which I'll briefly mention, and that is for hospital inpatient drugs. All formulations, those are generally included in the bundle payment that the hospital gets for an inpatient admission, a DRG payment. And in that context, the fixed payment that the hospital is going to get makes them very price-conscious customers, because they're facing a fixed reimbursement. They can't pass on drug costs in a fee-for-service manner, and so they are more price-sensitive. Okay, so looking first at how we deal with the pharmacy-dispensed drugs. We use so-called PBMs, pharmacy benefit managers, or some health plans manage it themselves, to create formularies that have tiers with different co-payments. And the name of the game is that they negotiate discounts from manufacturers in return for putting a drug on a preferred tier with a lower co-payment. And so the incentive for the manufacturer is, if we give a discounted price, we'll get a higher volume. It's discount in return for volume. And that has worked pretty well for drugs that are very close substitutes, many of the oral drugs, traditional drugs, and also for drugs with generics, where basically if the originator drug is off patent and there is a generic, the PBMs will put the generic on the lowest tier with a $0 to $10 cost share for the patient. The originator drug, the now off-patent originator drug, will be on the non-preferred tier with a very high cost share, and all the patients choose the generic. So that's how we get very high generic utilization in the US. And PBMs also negotiate discounts on pharmacy dispensing fees and operate mail-order pharmacies.
So was it the PBMs that negotiated the low, no-cost generic list that a lot of the commercial retail pharmacies now advertise on TV? Was it the PBMs or was it the retailer who said, we've got a market here?
Yeah, in some cases it was the retailers going after the uninsured patients and saying, like Walmart, I think, had a list of drugs that were available for $4, something like that. And that was really targeting the uninsured patients.
So the PBMs were not in?
The PBMs were not in that.
Okay.
But most of the PBMs have copay levels for the generic tier that are in that range, for $0 to $10, and that is a very powerful financial incentive for patients to accept generics rather than the branded product.
Can I just add one other thing, and that is that something that most people are unaware of is that the dispensing fees in pharmacies have essentially disappeared. The average dispensing fee now per prescription is around $1, which is not sufficient to cover the time of the pharmacist or any of the operational costs of the pharmacy. So essentially, the PBMs have been very effective at negotiating away the portion of the price that historically would have been the portion of profit that would have been used by the pharmacy to provide the service. So I just want to say that that's an important, they were very effective in that component of the negotiation.
That is absolutely true, and one of the early studies that was done on how PBMs were getting their cost savings found that essentially there was an equivalent saving coming from driving down the pharmacy fees and the drug prices. So the two were of equal magnitude. Which is why there is no love lost between the retail pharmacies and the PBMs. The operation of mail order pharmacies contributes to that too, but that's for another day. So basically, PBMs have been very successful in negotiating price discounts on drugs, where in therapeutic classes where there are multiple compounds that are basically undifferentiated, close substitute from a clinical standpoint, where there's no life-threatening condition for the patient, and really the physicians and patients have no strong preferences, so they're willing to let the PBM make the decisions about what the preferred drug is. But PBMs are much less able to influence use and negotiate discounts on the more differentiated drugs, which is most of the new drugs, the specialty drugs, where there really is difference between the individual drugs in a therapeutic class, and patients and physicians have preferences and often are managing chronic conditions by sequencing the different drugs, and there is just much less ability of the PBMs to treat them as substitutable. And so what the PBMs have generally been doing is putting those specialty drugs on a fourth tier with a co-insurance percentage of the price that on average is between 20 and 30% of the price. And so that is a significant percentage of some high-priced products. For Medicare Part D, which covers outpatient drugs for seniors, they have basically, because Part D is administered by private prescription drug plans that follow the same basic business model as the PBMs, it's a very similar approach that PDPs use formularies, they negotiate discounts, and they have some additional restrictions, but they operate pretty much like PBMs. And they, by law, can put on a specialty tier all drugs that cost at least $600 per month. And they can charge up to a 33% co-insurance to the patient. And so this data is a little old, but it's showing as of 2003, the Part D cost sharing amounts for generics were $2 to $5. For the employer-based plans were $10. These are average amounts. Preferred brand anywhere from $30 up to $45. Non-preferred brand $52 to $90, and then the specialty tier 26 to 33%. And that's for a month's prescription. So if you've got patients who are on several prescriptions, that's real money. Especially when you're talking about 33% of a drug that may cost $100,000, it seems like pretty irrational pricing to be charging those high prices, because most patients would not be willing to pay that sort of amount out of pocket. And so why are companies charging these high prices? Well, I would submit that one reason is that for good insurance reasons, most of our health plans have a catastrophic limit on patients' out-of-pocket costs. And if we look at the structure for Medicare Part D, as I'm sure you all know, there is a deductible, then there's an area where there's a patient co-insurance at 25%, then there's the famous donut hole where there's no coverage. But then when patients have paid a certain amount out of pocket, they reach this catastrophic threshold beyond which they are fully covered. So in Part D, there is normally a 5% that they pay, but pretty much Medicare, i.e. the government and taxpayers, pay 80%, the PBM or the PDP pays 15%, but the patient is protected against financial costs, out-of-pocket costs beyond that threshold. And the same is true in the private sector. Most plans, and under the ACA, under the Affordable Care Act, all new plans have to have an annual stop loss, an annual limit on patients' out-of-pocket costs. Now, if you think about it, a patient who's paying 30% of a drug that costs $100,000 has blown through that upper limit. They're looking at, if it's 30% of $100,000, they're looking at a cost sharing of $30,000. They're going to pay up to their out-of-pocket limit, which is the $2,500 or the $5,000, whatever it is. But beyond that, they're protected. And from an insurance standpoint, that's good. But they're totally indifferent to what the price is beyond that upper limit. And for them, it doesn't matter whether it's $100,000 or $200,000. There is no price sensitivity on the patient beyond that upper limit. And that is basically the situation that we've created. In the interest of creating insurance for patients, we've put these limits on that create a zone beyond which the patient has no incentive to care, and from an insurance standpoint shouldn't care. And so we've seen all sorts of reports of rising prices. This was a Wall Street Journal article about price increases on the 30 top selling drugs between 2010 and 2014, going up 76%. This was a Bloomberg article on the increase in prices for a number of leading drugs in a number of important classes. And this was an even more dramatic article on price increases for the MS drugs, for the disease-modifying therapies for MS. That's the very steeply rising line, and comparing that to the increase in prices for the TNF inhibitors. But the basic message, which we're all familiar with, is that prices for certain classes of drugs have been going up way more rapidly than the general cost of the consumer price index or any measure of cost inflation in the economy widely. And this is year-on-year price increases for existing drugs. It's not counting in the fact that new products launch at higher prices. So this is a pure measure of price inflation. And yet, in other classes, there certainly appears to be competition. And so this is from Novo Nordisk's annual report. As you probably know, they specialize in the diabetes class, which has fairly crowded classes. And what it's showing is the growth of discounts in this class. So the total bar is their gross sales, but the hatched amount is what they're giving back as discounts to the PBMs and the health plans. And so in some classes, discounting is working. The other class, I don't have a slide on it, but is the hepatitis C class, where, as was mentioned earlier, the payers seem to be negotiating fairly significant discounts. They're confidential, so we don't know exactly what they are, but we hear reports of significant discounts. And so what the situation is in some classes, there are enough competitors and there is a price sensitivity in the market so that our old mechanisms seem to work. But then there are other classes, which are the classes where the drugs are differentiated, where physicians have reasons to prefer one drug over another, where they're managing a chronic condition over a patient's lifetime and they intend to move from one drug to the other, where there is just not going to be any price sensitivity in that market, especially when patients are protected by the catastrophic limit on their cost sharing. And other factors that make the market less price sensitive and enable high prices and price increases are the copay coupons and patient assistance programs, which are available for some but not all patients. So in principle, patients on Medicare and Medicaid can't get those things. And so it's not everybody that's covered. But in general, I think the one way the ACA has contributed to the rise in prices is this upper limit on patients' cost sharing, which, as I've said over and over again, I think we want as good insurance. The ACA also removed the ability of health plans to limit what they pay on covered benefits, which meant that that price sensitivity that used to exist for health plans has now been removed because they cannot cap the amount that they will pay for expensive drugs. Or expensive treatments in general. It's a small number of patients who are affected, but it is patients on some of the very expensive drugs like the orphan drugs. So that's the patient pharmacy dispensed drugs. For the physician dispensed drugs, the incentives that have been created are even more perverse, I would submit. So we have this rule that Medicare Part B pays average sales price, which is the manufacturer's average net sales price, the net of discounts, volume weighted, plus 6%. The rational pricing strategy in this context is to charge high prices, because the higher the price, the ASP, the larger that 6% is in absolute dollars for the physician who is making the decision. And Medicare has just recently said they're going to run a demonstration project with a slightly different reimbursement formula to see if this makes any difference. But you know, it's not rocket science to see that this does not create much incentive to compete on price. On the contrary, it rewards naming high prices. And the private plans have basically followed Medicare. There is some move, especially under the ACA, to try and move towards bundle payments, and bundle payments for providers that include drugs will make the providers more cost sensitive. And that already exists in the hospital sector. So we saw in some of those cases, some hospitals are stocking products that have very high prices relative to what they're being paid under the DRG payments. And there is an attempt by Medicare and other payers to move more outpatient care to a bundle payment. So for example, a payment per month of treatment with a patient with a particular condition. But it's much harder to measure a constant unit of output in the outpatient sector, and so that idea has not had much progress. Medicare Accountable Care Organizations, also something in the ACA that are intended to give providers an incentive to collaborate and control costs while maintaining quality of care. I think most analyses of these ACOs suggest that there's not much incentive for cost control in them, and in any case, the Medicare ACOs exclude outpatient drugs. So they're looking at controlling costs under Part A and Part B of Medicare, not Part D, which is the outpatient pharmacy benefit. So I wouldn't put a lot of hope in that really making much difference. But there is, sorry, I flipped through this first. There are some proposals coming forward from various sources for a more value-based approach to assessment of price and utilization. And I want to start off by mentioning a couple of proposals that have come out of the medical specialty societies recently. The first is from ASCO, the Association of Clinical Oncologists, that developed a conceptual framework to assess value of treatments. And this was developed to assist physicians and patients in their choice among drugs, not as a price control approach, but simply to assist in choice between drugs. What they recommend as a measure of value is a measure of outcome, which they would measure by clinical benefit plus toxicity relative to cost. Clinical benefit would be measured by overall survival, progression-free survival, relative risk from clinical trials with all its warts and problems. And then they would measure this on a 1 to 5 scale and weight it and add a weight for toxicity, so that's all a bit ad hoc. And then they would compare that to either the drug acquisition cost, if it's a provider making a decision, or the patient cost, the cost sharing if it's a patient making a decision. Now, I don't want to recommend this particular approach. I think it has many flaws, but I would say it's a step at looking at value in terms of clinical benefit measured as some measure of clinical benefit relative to cost. The second approach that has come from the clinical specialty societies is the cardiologist's proposal for a value methodology that they would use in setting clinical guidelines. So not in influencing prices, but influencing guidelines and deciding what is good value and should be put in priority in clinical guidelines. And importantly, they start off this article by recognizing that they take it as their responsibility to consider the societal perspective in setting guidelines and to recognize that as a society, we have finite resources to spend on healthcare. And therefore, we should be trying to maximize the health that we buy with what we spend on healthcare. So their criteria is to maximize health gain for the budget available. And that is what they're thinking about in setting guidelines. And with that in mind, they recommend considering value measured by an incremental cost effectiveness ratio, or an ICER, that is defined as the incrementing cost of the new treatment relative to the alternative comparative treatment, relative to the increment in some measure of health gain. They use quality adjusted life years, or QALYs, and they recommend using the total drug cost, which includes the drug price, net of any other resource savings. So it's the societal measure of the medical cost that results from using the drug, which if a drug saves inpatient costs, for example, that savings would be netted off against the price of the drug. And they are looking at it from the perspective of society buying the drugs. So they're not trying to measure what the costs are to the companies, they're trying to measure the cost to society, which is indeed the price of the drug. And looking at that relative to the measure of health gain. They don't take a position on what is good value, but they simply reference the WHO guidelines, which are that for any country, a product that has a cost per incremental QALY that's more than 3 times GDP per capita is high cost or low value. So in the US, that would be anything that costs more than roughly $150,000. Our GDP per capita is roughly $50,000, so anything costing more than $150,000 per quality adjusted life year gain would be considered low value, and anything costing less than 1 times GDP per capita, so for the US less than $50,000 per quality gain, would be considered high value. So that is their proposal. Finally, this is the proposal that I and my co-authors Adrian Towers and Jorge Mestres proposed in an article in Health Economics in 2014. which ends up looking fairly similar to what was proposed by the cardiologists, but we're proposing it as an indirect approach to price control. And so the idea is that the payer would evaluate new drugs relative to current treatment and evaluate the cost effectiveness of a new drug by looking at the incremental cost, which includes the price of the drug and any cost savings or cost offsets, relative to the health gain, which could be measured by QALYs, which could be measured by however a payer wants to measure it, and consider that good value if the incremental cost per incremental unit of health gain is less than whatever the payer's threshold is. If we take the WHO guideline, say 150,000 per QALY, and that the payer should reimburse for drugs, for indications for patients who meet that expected threshold. So that payers would be spending their money on products that deliver at least a QALY per $150,000 spent. If the payer were to set some threshold, and it could be it could be 300,000. You know, we're not taking a position on what the threshold should be. But if there is a threshold, what that does is it creates an incentive for companies to price their product in a way that is commensurate with the value that is created by the product. Because if you take the equation for the ICER that I had on the previous slide, and just rewrite it and solve for the maximum price at which the new drug would be cost effective, that maximum price is the price of the old drug plus any gain in savings plus any gain in efficacy valued at the payer's willingness to pay per QALY. And so if the new drug is just equivalent, has no benefit relative to the existing drug, it would be reimbursed at a price that's the same as the existing drug. If it delivers cost savings or improvement in efficacy, then it would get a price premium. And so it is a way of putting a limit on the prices that a payer would pay that does maintain incentives for innovation. Because if a new drug produces additional value, it will get a higher price. But if it's no better than the existing product, it won't. And so there are all sorts of details that could be worked out that could differ across payers. Payers may have different thresholds. In the US system, they may choose to measure QALYs in different ways, or there could be different thresholds for orphan drugs, for example. But this general idea that we should have in mind a willingness to pay per unit of health gain and use that as a way of indirectly limiting prices, but at the same time pay more for things that deliver more value, that would limit prices while preserving incentives for innovation. So my conclusion is that the high and rising drug prices which we see in the US are a reflection of the insurance systems and the reimbursement rules that we have created, that we do face a difficult challenge in wanting to provide good insurance for patients, which means limiting their out-of-pocket exposure. But if we do that, we need to recognize that our old approach of relying on patient cost sharing to be the moderating influence on pricing just won't work because we protected patients. And so in that sort of situation, we need to, for payers, to put in place some sort of limit on what they will pay that is based on an approach that thinks about the value created, so that we preserve incentives for companies to invest in new drugs that do produce more value. And we're willing to pay for those, but we're not willing to pay unlimited amounts. Because at the end of the day, we do have limited resources, and there is an opportunity cost when we spend very high amounts, much higher than the 150 or even 300,000 per QALY. There is an opportunity cost. We give up something elsewhere in the budget. So some approach like this, I think, is justified in a situation where we give patients good insurance protection. Okay, thank you very much.
Professor Dazzle, I would like to ask you a little bit more about the distinction between the parts, the segments of the market which don't seem to be working because price inflation simply skyrockets, but other segments in which it does, such as you mentioned some of the diabetic drugs. But what exactly is it that distinguishes those two kinds of markets, given that the patient cost protection is the same for both, and that even some, you mentioned that for drugs that are more different from one another, and there's patient variation in what the individual patient might need, that's going to be a harder situation. But the example that comes to mind is the phosphodiesterase inhibitor market. Drugs for erectile dysfunction, which is a very mature branded market. The patent for Viagra is about to expire in the next several years, but that's an example of this skyrocketing price inflation from the beginning, which continues on an annual basis. And why would we not see the kind of discounting in the diabetic market, in a market like that one?
You know, that's a question that hasn't really been well researched, and it's very difficult to research because the discounts are confidential, as you know. All I can say is that from what I've heard from payers and also from clinicians, that there is, in certain classes, clinicians are just not willing to shift patients from, if a drug is working for a patient, they will not shift for some modest difference in price, particularly when the patient is protected and they're not actually bearing that difference. And so those chronic medications where a disease is being managed over a lifetime are probably the most price insensitive. The hepatitis C market is interesting because that is a case where it's a complete cure. Among the newest drugs, they're pretty much equivalent. And so it doesn't really matter which drug a patient gets. Either one of their packages is going to work. You're not managing a patient over a long lifetime. And there's a very strong incentive for those companies to give discounts because there is a big backlog of patients whoever the first companies to market, they will get those patients. Once those patients are being treated, the annual volume is going to be much lower because that volume of patients in the backlog is being treated. And so there is a real price competition going on between the companies to get that huge backlog that exists. And after that, they know the market will be smaller. So that is sort of an unusual situation where everything is set up well for price sensitivity. There are other markets that I find much more puzzling, but I think in the ones where we see those big price increases, oftentimes there is this, the drug works for the patient, I don't want to take them off it, because not every drug manages every patient in an equivalent way, and the patient is not suffering any financial inconvenience. So it's not a great answer, but that seems to be the problem, and it is one that means that for many of the new drugs, because so many of the new drugs and this is good, are intended to be differentiated. We want differentiated drugs, but that will mean that the normal situation will be we will not have a lot of very close substitutes competing head to head.
So I'm interested, is there any effect, and again, I'm not an economist, so again, if we look at the global market and we consider the United States as an isolated, is there no influence from the way the rest of the world works on the United States market? And what would happen to the pharmaceutical industry if the United States adopted more of a European model in terms of approvals and usages of drugs. What's your opinion?
Yeah, so my opinion is that there is very little effect of the rest of the world on US pricing. If you simply ask yourself, if the rest of the world were to pay 20% more, do you think our prices would come down? Unlikely. Now, if we were to pay 20% less, would there be some effect on R&D? Yes, possibly. So I think that the idea of cost shifting, that somehow our prices are high because other companies are paying less, that doesn't make sense in economics. In each of those markets, companies are charging what they consider the profit maximizing price. And we are sufficiently separate from those markets that we are not being influenced by their prices. Now, if the US were to adopt an approach that was to say, and this was proposed under the Clinton healthcare proposal way back in the 1990s, the US will not pay a price that is above the lowest price in a group of 20 countries. The effect of that would be that companies would seek higher prices in those countries because the US is such a large part of the market that it is better for them to try and get higher prices and lose volume and lose sales in those markets rather than bring down prices in the US. So it would be a very unfortunate and a very unsociable thing for us to do. We are wealthier in general than most of those countries. And if we do try and base our prices on them, they will suffer. And we do see that, and I've done research on this, in Europe, where there is quite a common practice of countries basing their prices on the lowest or the average EU price. What happens is that companies are reluctant to launch in the small, low-price countries. And so you see a real dearth and delay in launch of new drugs in countries like Portugal, for example. And so it is very much a kind of better your neighbor policy for us to do that. And similarly, the proposals that we would import cheaper products from other countries, the effect might be that companies would be less willing to sell at lower prices if the odds are that those lower prices would just be imported into the US. Now, that's not the only issue with drug importation proposals. Most of those proposals exempt biologics, which are the highest priced products, so it's not going to affect those. But generally, I strongly believe that each country should decide what we are willing to pay for health gain, and let them decide what they're willing to pay, and then companies will face the appropriate incentives because each country in the globe will be paying what they're willing to pay for health gain, and that creates an aggregate incentive for R&D that reflects the global willingness to pay. So free riding in any direction on other countries' lower prices is bad for, particularly for the lower income countries. Yes? Amy?
Thank you for that explanation. That was very helpful. Concerning the proposal that you and your colleagues came up with and published 2 years ago, I'm curious as to whether it has gained much traction. And,
No.
And what your next steps may be to promote it.
Well, I am heartened that there are these proposals coming out of the medical specialty societies to look at value, and that is helping fuel the debate that there should be some relationship between value and price. And I am hopeful that we will continue to push that sort of debate forward and not be sidetracked by people who say, well, we'll just end up with lack of access to drugs as in the UK. Now, it is true that the proposal we put forward looks fairly similar to what NICE does in the UK. But what is critical to this proposal is the threshold willingness to pay that the payer adopts. NICE in the UK has a threshold of around £30,000, which is around $50,000. In the US, we already pay much, much higher prices than that for many drugs. So if we were to set a willingness to pay threshold that is more commensurate with what we are willing to pay for healthcare, I don't believe we would see the sort of reluctance to launch in the US that has happened in the UK, where companies are not so willing to launch because the limits on price that implies in the UK. The other difference between the US and the UK is that the UK is in Europe, and there is a tendency for other European countries to look at the UK prices and say, well, if we're giving that price in the UK, we're not going to pay more. And so that the UK price is sort of a bellwether for what prices will be in other countries. And we're not so much part of that international referencing system, fortunately. And hopefully that will remain the same.
So in the early part of your presentation, you outlined the different mechanisms for which drugs are paid for when they're purchased in a pharmacy versus when they're provided as a part of physician dispensing and so forth. One of the things we really haven't talked about are the economics of a drug that is purchased but then not used correctly or not taken at all after it's used because the patient has misunderstood instructions, directions, or has decided that they're not going to use it after they've purchased the product and it can't be returned. So the problem is, in my mind, that the payor, the original payor, is disinterested in that issue after it happens. The PBM, for example, is reimbursed by the employer or by the government or whomever for the drug. Once it's dispensed, that transaction's occurred. If the patient takes it, that's fine. If the patient doesn't take it, that's fine. On the medical side, the medicines typically are provided and administered within the physician's practice, so there's a little bit more control of that. But even in that environment, that's not always the case with oral chemotherapeutic agents, perhaps, or maybe some other things. And that side is also not concerned with the PBM side because they're. So is there anything happening in more of a macro sense in terms of payors and payment? Because I think that's another consideration. It's very expensive. That drug becomes exponentially more expensive when it's not taken, and the side effect, the consequences of the downstream disease process causes the overall cost of healthcare to go up. Can you maybe speak a little bit about the payor changes that are happening to try to address that?
Yeah, I think that both the accountable care organization idea and the bundled payment approach are trying to create incentives for better use of healthcare resources, which would include making sure that compliance occurs where it's important to the patient's overall healthcare. I mean, in both of those approaches, the payment is going to, in a bundled form, for care of a patient over a particular period of time. And there is supposed to be payment contingent on evidence of some, complying with some quality metrics. And so in the Medicare ACOs, the ACO, which would include all the providers, they get a share of any savings from reducing costs of patient treatment relative to the average cost in traditional Medicare for the same type of patient, conditional on having net quality metrics. So the idea is that then the providers will have an incentive to do disease management and have case managers to make sure that the care is being coordinated in the way that is essentially producing the best health outcome for the money spent, because they will share in the savings. Now, what happens in practice versus what is the ideal. I think we're a long way from having really got to that ideal. But the optimistic part of it, I think, is that there is that movement towards that change in the reimbursement system happening in the private sector as well as in Medicare, and that part of the criteria for being part of those systems is that the providers have to show evidence of having data systems and having protocols in place where at least there will be a sharing of information and hopefully knowledge about what happened in one part of the patient's treatment versus the other part. So at least the issue of not knowing will be addressed. So gradually we're groping towards something, but are we there yet? No. But there is some progress, I guess I would say. And I would also add, I think that that is true of every country, that it's not, that that's sort of intrinsically difficult within the healthcare delivery system, because we want to have care from specialists, but that means coordination. That's tough. That's true.
I was going to ask if this method is similar to NICE, and so I was glad to hear that it is, except the thresholds are higher.
We are not proposing a particular threshold.
Yes.
But all I'm saying is that I would expect that in the US the threshold would be higher, because we want to look at what's the, what's the...
So I want to ask you if you happen to know much about how the VA is doing this. So the VA has much more clearly a firm fixed budget. It has unusually sick population, and it has this whole cost effectiveness review system for assessing new drugs. Are they using a method something like this?
I would defer to my colleagues who work in the VA. Tom, do you know?
I would love to know, but unfortunately I don't.
It seems to be, it's the living, real American example.
Sure.
Plus Kaiser and Intermountain in Utah. These are all...
Kaiser certainly uses cost effectiveness analysis very similar to this, and has a more restrictive range of things available, and yet has very good outcomes. And I think clinicians and patients generally feel that they can get what they need. And I was interested to hear, Tom, I think you said the same about the VA, that you think that even though it is constrained within a budget and is certainly making choices, that generally you can get what you need.
So, the AC movement was based on the inspiration of things like Kaiser, but then the ACOs are much looser in their definition. They don't cover drugs, for example. They don't have responsibility for budgeting. But it's important to realize we have real, working, successful examples of this in the United States, developed to a highly sophisticated level, constantly being refined. Particularly impressed by Intermountain because Fred James does such a fabulous job measuring outcomes.
I think we're standing between you and lunch. Right?
Yeah, lunch may actually not be here. They're set up, but I haven't seen the food yet. So in the next 15 minutes, lunch will be here, though. So if we want to go for...
If anybody wants to continue general discussion.
I'm going to check.
Oh, well, I want to ask something else. Just, how are qualities measured? For instance, if this patient has mild arthritis all the time, is that 1/10 of a quality, or 2/10 or 3/10, or take your adolescent patients who are in mental suffering? How much of a quality lives on them?
There are standard essentially tables that are both general and disease-specific, which essentially put values on health states, where those values have been solicited from patients, from physicians, from wide groups of individuals in different walks of life, but including patients, and then validated across different groups. And so there is a big investment in coming up with those tools for measuring the quality, the utility that individuals and patients put on different health states. and actually European countries are in the business of recalibrating their Euroqual. And it is important that a payer should use a consistent set of metrics across different diseases and across different drugs, so that when they are comparing one with the other and trying to determine what the value is from this drug versus that drug, that it really is an apples to oranges, an apples to apples comparison, and they're putting the same value on different disease states. Now, it is also true that, obviously, if we measure QALYs in the sense that a QALY is a QALY is a QALY wherever it occurs, it is intentionally saying we're going to treat all patients the same, and if patients are getting towards the end of their lives and are intrinsically in worse health, that will get a lower weight than young, healthy patients. And that is, we all get a chance to be young, and we all hopefully get a chance to be old, and that is the reality of things. So it will, if you treat it as a QALY, as a QALY, as a QALY, then it will tend to focus investments on the sorts of treatments that can preserve people in good health and put relatively low value on things that just extend life at the end of life with very little improvement. And they would argue that is how we want to spend our limited resources. And they are willing to have that discussion, which, to go back to the opening talk, in the US, we've just not been willing to take on that discussion at all.
All right.
Some people stand up and ready to go.
We'll take a break. When lunch gets here, it's here now. Okay, great. And we'll reassemble and we'll start at noon, but please take your time, get your food. And we won't start right at noon, but we'll get started shortly.
And I do want to make one note that the agenda for the luncheon is in your packet, but there's a typo that says that the luncheon's in the Howard Room of the Ralph Beeson University Center, but it's not. It's right here. So don't take your plate over there. Thank you.
Again, for being here, and for those of you who may not know, the Pellegrino Medal was established in 1999 by the advisors, faculty, and fellows of the Heal Institute as a mechanism to honor individuals who were recognized nationally as leaders in contribution for healthcare ethics and their selfless spirit, which definitely was demonstrated by Dr. Edmund Pellegrino. In 1998, Dr. Pellegrino received the first Lifetime Achievement Award granted by the American Society for Bioethics and Humanities. And at the presentation of that award, he was called the Father of American Bioethics Movement. Dr. Pellegrino, who passed away a couple of years ago, was very honored and delighted that Samford University and the Heal Institute established this medal in his honor. And he was, of course, the first recipient of the medal. And so, in following with great tradition, we will honor two individuals today with the Pellegrino Medal. Before I turn it over to the individuals who will tell us about our honorees, I also want to mention to you that the Heal Institute was really founded and stimulated based upon the strong interest of Mr. R. Clayton McWhorter. Mr. McWhorter had a strong understanding of the importance of particularly hospital ethics committees and the role of the ethical decision-making in hospitals and health systems. Having served as the CEO and chairman of the board of the nation's largest health system, Mr. McWhorter knew that there needed to be investments in providing opportunities for networking and education about important bioethical topics. And so he put forth the initial lead matching money to be able to establish the Heal Institute. And that money, of course, was matched by several other donors beyond Mr. McWhorter, most notably Baptist Health Systems. And so we want to thank Baptist Health Systems for their sustained support over the years financially of the Institute. But I also want to just mention to you, as many of you are already aware, Mr. McWhorter passed away after a very short battle with cancer earlier this year. And we are deeply saddened and feel the effects of his loss each and every day. But I thought that we would just take a moment to bow our heads in silence in recognition of Mr. McWhorter. Thank you. And now I want to welcome up to the podium Dr. Tom Huddle and Dr. Dennis Sampson, who will tell us about our honorees. Tom, you first.
It gives me great pleasure to introduce as one of this year's Pellegrino Medal honorees, Professor Patricia Danzen of the Wharton School of Business at the University of Pennsylvania. I first encountered Professor Danzen's work about 10 years ago in the course of trying to understand the pharmaceutical industry as a means to think about the ethics of physician engagement with it. And as I'm sure many of you who have confronted an unfamiliar literature and tried to begin to understand it have found, as I began to work out the lay of the land in economics literature on pharma, I could soon begin to distinguish the work that was essential from the work that was less so. That is the work usually in the best journals that set the agenda and shaped the conversation on one hand, from on the other hand, the work that was responsive to and derivative from that work that was of central importance. And it became clear to me almost immediately that in the realm of pharmaceutical pricing, Professor Danzen's work was the indispensable center. It was the work that anyone hoping to master the policy debates over pharmaceutical pricing had to reckon with. That her work would be preeminent in a critical area of health economics over the course of an immensely productive career was presaged very early. After she graduated from Oxford with a first in policy, philosophy and economics, she began graduate study in economics at the University of Chicago. And her dissertation committee there was headed by the Nobel laureate George Stigler. But his luster did not eclipse the other members of her dissertation committee, which happened to be Ronald Coase and Gary Becker. After such a start, it was hardly surprising that Professor Danzen would go on to distinguish herself in economics. When she left Chicago, she became a research economist at the Rand Corporation, spent a few years there, moved on to the Hoover Institution at Stanford, eventually spent a year at Duke University in the early 80s, and then reached her academic home in 1985 when she became the professor of healthcare systems, insurance, and risk management, the Celia Mose professor in the Department of Healthcare Management at the Wharton School. She's produced an immense body of work, a profusion of books, journal articles, and book chapters. She's received awards from the American Risk and Insurance Association, the Agency for Healthcare Research and Quality. Her expertise has been sought by the AMA, by the American Hospital Association, the World Bank, the Asian Development Bank, and Rand Corporation's Institute for Civil Justice, among other governmental and non-governmental organizations, including pharma. She's a member of the Institute of Medicine and of the National Academy of Social Insurance, and she's been associated editor of the American Economic Review, the Journal of Health Economics, and the International Journal of Healthcare Finance and Economics. When I first began to absorb her work on pharmaceutical pricing, I imagined that she had succeeded by specializing, as so many academics do, by focusing on one area exclusively and making that area her own. How wrong I was, as Professor Danzen has done seminal work in a range of areas in health economics, including international health system comparisons, tort liability, liability insurance more generally, and in particular medical malpractice, on which she published a landmark book in 1935. Now, it may seem odd to some of you that the Pellegrino Medal, granted for contributions to healthcare ethics, is being awarded to a health economist. But I think the award to Professor Danson rightly recognizes that economics at its best is a humanist as well as a scientific discipline. And as we saw this morning in her talk, it's rich with insights to offer to highly normative enterprises such as public policy making. Her work is that kind of economics, rife with ethical implications, and she's a deeply worthy recipient of the Edmund Pellegrino Medal for 2016.
For the last 15 years, the Health, Ethics, and the Law Institute of Stanford University has sought to recognize scholars and medical practitioners who, by their publications and works, have advanced the visions and goals of Edmund D. Pellegrino, who died in June 2013. Pellegrino was a renowned physician, as has been said, and an educator as well, who thought healthcare in all its expressions rest upon important ethical commitments and common human experiences. We endorse this vision and try to perpetuate it by giving an award in his name to people whom we think, in their own ways, carry on that vision. The famous philosopher Aristotle claimed that justice is the chief of the social virtues. It entails all the others. If you are just, you will be generous, courageous, friendly, and so on. A just person experiences the deep gratification of a well-lived life because this person contributes to the human flourishing of others. In particular, Aristotle thought a just person would be concerned with how social goods are rightly made available to all people. For a society to experience fulfillment, her citizens should have opportunities to fulfill their natures as social and rational beings. Hence, we should promote what he called distributive justice. That is, people should have access to the social activities which are relative to their needs and necessary for living in an intentional and coherent society. A just society affords these social goods to her population, and a just person is thus committed to the proper distribution of these social goods. Throughout Dr. Light's work, we see this emphasis on distributive justice. For instance, in 1996, he published through the Oxford Press with Norman Daniels and Roland Kaplan the book Benchmarks of Fairness for Healthcare Reform. In 2006, he published in the British Medical Journal an article titled Commercial Influence and the Content of Medical Journals. In 2007, he published in The Lancet, Is the G8 Putting Profits Before the World's Poorest Children? In 2011, he published in the American Journal of Public Health the title, The Inverse Benefit Law, How Drug Marketing Undermines Public Safety and Public Health. In 2011, he published Demythalizing the High Cost of Pharmaceutical Research in the journal Bioscience. And then in 2015, he published the book, which he has shown here, Good Pharma, and on and on. Dr. Light's concern, it seems to me, is not necessarily to inveigh against the various industries which are necessary for the delivery of healthcare to society, but with the practices and perhaps unaware biases within them that prevent distributive justice, that put obstacles between what people need so to flourish as persons within a just society and the availability of these social goods. His point is that healthcare is a social good, that society should make available to people so that the people experience well-being and consequently contribute to the well-being of society. It is a matter of justice. It is a matter of ethical commitment and common human experience. It is a vision we have here in the Hill Institute and a vision Dr. Light has. And for that reason, it is proper for us to confer on Dr. Donald Light the Edmund D. Pellegrino Award.
If Dean Michael Crouch, the Dean of the McWhorter School of Pharmacy, would please join us here at the stage. And would our two awardees please join us at the front. to both of you, this certificate and accompanying medal acknowledge you and your contributions to healthcare ethics in the selfless spirit of Edmund D. Pellegrino, awarded this 15th day of April 2016.
I think I'd just like to say thank you, and I'm deeply honored and pleased to be here. You've had enough of me already. But I would like to thank Tom for that very generous introduction.
And I also feel very honored and thankful. I don't have much to add and very much appreciate the presentation.
So at this point, we will take a...
When I was using my classroom voice, that wasn't quite loud enough. I've been really pleased with this conference today. I just wanted to say that. And I think one of the wonderful things about this conference is the diverse perspectives that are being offered, and we'll continue with that. This afternoon, our speaker is Richard Smith, who is past Executive Vice President for Policy and Research at the Pharmaceutical Research and Manufacturers of America. Now, I am supposed to tell you that we appreciate and we are thankful to the Pharmaceutical Research and Manufacturers of America for sponsoring this talk, but also there's some boilerplate. I have to warn you, he actually might give an industry perspective. So there could be a conflict of interest. But just to make that really obvious, the name of his talk is The Pricing of Prescription Drugs and Industry Perspective. Okay? But we're fortunate to have him here today. He has been working policy at both state and federal levels, so he's got a wealth of experience in health policy with specific application to pharmaceuticals. So thanks so much for being here, Rich.
Thank you. First, my congratulations to the awardees. Second, my thanks to all of you for inviting me. Actually, until you said it, I did not know that Pharma was sponsoring or helped sponsor this event. That will not make a difference in the fact that I will, in fact, be giving you what is for me a deeply held perspective about the industry from an industry perspective. So let's see. All right, so I'm going to cover several topics. I have way too many slides, so I'm going to just speed kind of through them. So we'll start with medical advances. I actually think that there's a pretty good track record. I think that if you compare where we are today with medicines and the ability to treat patients with difficult diseases, we've come a very, very long way in over recent years and over the decades, really. And I'm not going to say that everything that has been achieved is achieved solely because of industry. That's not the case. There are lots of participants, but industry is both a necessary and an essential participant. It has played a very large role in these achievements. I'll come back to HIV and AIDS a little bit later, but of course we're all aware that there's dramatic turnabout from where things started. I was talking with a friend a while back who said he was on Capitol Hill a while ago, and he mentioned the so-called AIDS quilt. I don't know how many of you remember the AIDS quilt. And the people he was talking to, who were mostly kind of younger staffers, had no idea what he was talking about. So real transformation in disease that I think is born enormous benefits. Cancer, we are seeing significant progress. We're seeing declines in cancer death rates. There's a lot that needs to be done. The president has a moonshot because he wants to get more done. But there is a lot happening. I'm not going to tell you that cancer is going to be cured tomorrow. I'm not going to tell you, that there's going to be breakthrough after breakthrough. I can tell you that there's developments that I think are recognized as really important. There's personalized therapies that are targeted, so we have a much better chance of getting them to a patient who works, and the pipeline is very full of those types of medicines. And we've had very significant advances in immunotherapy that if you talk with oncologists, I think that they'll tell you we think we have something very, very important here. Again, it's not going to cure everybody tomorrow. I'm not going to say that, but we're making progress on the dimensions that I think were not viewed as possible not that many years ago. And we could go through, a number of other areas where there are really important developments, cystic fibrosis, where for a very small population at the moment, a very small subset of the CF patients, we actually have the first medicine that intervenes in the underlying disease process rather than simply treating the symptoms of the disease. And I'll note that it's often tough work, and we often fail. We fail actually quite a lot. Over the last 15 years, there were 96 unsuccessful molecules put into trials for melanoma, 7 successes. For brain cancer, there were 75 unsuccessful, 3 successful. For lung cancer, 167 unsuccessful, with 10 successful. And for Alzheimer's, 123 attempts with 4 medicines, and obviously we have a long way to go. Those 4 medicines aren't anywhere near where we want to be, and obviously Alzheimer's is one of the central areas that the industry's research apparatus is focusing on. I think we actually have a pretty good record of focusing on areas of high social need. Cardiovascular care, #1 killer. Ernie Byrne from MIT and David Cutler from Harvard will tell you statins in a single year save about 86,000 lives, avoid 833,000 hospitalizations. And actually, we're still finding new uses for statins, which are now really, really cheap. People used to be upset, payers used to be upset about the cost of statins. I haven't heard anybody complain about the cost of the statin in a long time. So that's part of the process that I'll get to through the drug life cycle. So I've already talked about cardiovascular disease and declining death rates. This is not all drugs, but drugs play a significant role, as a quote from 2 Johns Hopkins cardiologists on the side of the slide show you. Protein enzyme receptors are channels identified by the pharmaceutical industry as druggable targets that led to striking, remarkable, and repeated achievement. And that's before some of the important advances that have occurred in recent years. I mentioned personalized medicine. So this is targeted therapies that are being developed with biomarkers that can tell you, is this medicine likely to work for a given patient versus not likely to work, so we don't need to give it to the patients for whom it's not going to work, and you can target it to the patients for whom it is going to work. This is a really important development, and we have 42% of new medicines in the pipeline have the potential to be personalized medicines. Not every one of them will actually prove out as a personalized medicine, but we will get an increasing number of personalized medicines out of the pipeline. And you can see in cancer, we're seeing an even higher percentage. I mentioned HIV/AIDS previously. Some work by some economists took a look at where the value of the lives saved through the dramatic turnabout in HIV landed. So this is looking at the value of those lives and those life years saved, and then looking at, when we monetize that, I think, in broad terms, similar to the way Professor Danson was suggesting, you could look at, QALYs. But looking at this retrospectively, as we have the proof of what's happened, they calculated that manufacturers captured about 5% of the total value generated by HIV medicines. And I will note that I think it's fair to point out that advances do require uniquely high R&D intensity. So what I've put up here is a slide from the Brookings Institution using National Science Foundation data that the Brookings Institution has a project on America's advanced industries. These are the industries that Brookings identifies as powering forward the U.S. economy. It's where innovation occurs, and it's where economic growth is driven from. They have 50 advanced industries that fit this bill, and of those 50 industries, the defining characteristics are R&D per employee, which they calculate from National Science Foundation data, and also the share of employees, or the share of jobs that require a STEM background. So on the dimension of R&D intensity, or the R&D per employee, the pharmaceutical industry is far and away number one at $130,000 per employee in the Brookings NSF analysis. And you can see the very significant drop-off to other companies. In fact, to make the list of the top 50 industries in the United States, top 50 advanced industries, an industry needs to have about $1,000, less than $1,000, I think it was maybe $800 per employee. So the pharma sector is somewhere around 150 times that research intensity to make it into the top spot. And you know, there are many other sources you can look at. Congressional Budget Office has identified the pharmaceutical industry as one of the most research-intensive industries in the United States. According to CBO, the industry invests 5 times as much per 5 times as much of the share of revenue as the average manufacturing sector. So I think that there's an enormous effort, and I think it's paying off. Putting drug spending in context. Today we've talked about medicines exclusively. We haven't talked about the health system as a whole at all. I think it's always helpful to think about the system as a whole and what role the medicines play in it. And here I'm showing a calculation of the share of total spending in the total health spending in the United States that has gone to medicines and that's projected to go to medicines. And this includes both the retail drugs taken from government data put together by the Medicare actuaries, and it includes the non-retail drugs calculated by the Altair Institute. And what you see here is medicines are a pretty steady share of total spending on healthcare, around 14%. So we have about 86% of all healthcare spending outside of medicines, about 14% inside medicines, and that's projected to stay roughly constant out through 2024. I'll note that you know, that share has remained constant and is projected to remain constant, even though we brought a steady stream of new medicines to patients. And I'll talk a little bit about how that happens. How can you have 500 new medicines over the last decade with a roughly constant share? And it's because we have a very aggressive system in the United States for driving cost containment, and it's because we have a prescription drug life cycle in which you know, very valuable medicines go generic. They're used for literally decades at very low cost. And I'll show you some data points on that in a little bit. And that's unique. We don't have generic hospitals, for instance. And I'll show you some data points on that. Whoop. Okay. All right, it doesn't want to advance. Is there a tech person here who might be able to help me?
The arrows. The arrows backwards.
Use the cursor.
Okay. All right. So here I'm showing you growth of retail medicines, and I should note retail medicines where a lot of the action has been lately. For instance, the new hepatitis C medicines are retail medicines, right? So we had a significant increase after years of historically low growth rates for retail medicines from 2008 through 2012. And then we had a significant increase with the introduction, principally of the new hepatitis C medicines that are curing a pretty nasty disease. What we see now is the growth rate is coming back down, and the growth rate is projected by Medicare's actuaries is in line out to 2024 with the rest of healthcare. Another way to look at this is where is the growth in spending in healthcare? And I hear a lot that the growth in spending on medicines is unsustainable. And I hear that really, only about medicines. And what we find here from new data issued by the Department of Health and Human Services is that when we look between 2009 and 2018, the years they looked at, the absolute change in spending on medicines is, in their projection, $181 billion. That's a lot of money. That's a lot of money, and we should be getting value for it. At the same time, the increase in spending on all other parts of healthcare that aren't medicines is about $885 billion. So for each dollar of increase in spending on medicines, we're going to have about $4.90 of increase in spending on the rest of healthcare. So I think this is important, not because it means there is necessarily something wrong with the rest of healthcare, but as we've had a debate about cost containment, the debate has been pretty much limited to medicines in recent years. And I think that you can squeeze on the medicine side, but contrary to a lot of what I hear in the debate, that's really not going to solve the healthcare cost growth issues that we have in the United States. And we really do need to think about what are we going to be doing across the system as a whole to keep healthcare affordable, rather than how are we going to squeeze down exclusively on medicines. Doesn't mean medicine should be exempt from cost containment. They shouldn't be. It doesn't mean medicine should be exempt from demonstrating value in the system. They shouldn't be. But it does mean that if we really want to tackle the problem of how do we get better health care more affordably, we actually need to look a little more broadly than we have. I should also note, I keep on using this term, how much we're spending on medicines. And the mental map that I've noticed most people have is all spending on medicines is assumed to go to brand manufacturers. In fact, spending on medicines breaks out in several different ways. A sizable share goes to brand manufacturers. Another share goes to generic companies, and then the distribution chain, and then hospitals. Hospitals often very significantly mark up the price of medicines, even though there are many hospitals, known as 340B hospitals, that actually get some of the lowest prices in the United States, statutorily required discounts that really drive the price down. But often those prices are marked up very, very, very significantly. So I think that as we think about medicines, it's important to think about all of these pieces. So in that 14%, we have brand manufacturers, generic manufacturers, the entire distribution chain, the share kept by health plans, in Part D, for instance, along with the markups from hospitals and other facilities. This is data that's taken from insurance rate filings, and this shows where the insurers allocated or how the insurers defined the cost increases that they were experiencing between 2015 and 2016 for purposes of setting their premiums in the individual and small group market. And what we see here is that from the insurer's own data, prescription drugs, and this is the retail drugs because that's the category on the insurance filings, accounted for $3.29 out of $25.26, and you see the various other categories that accounted for significantly more. Now, I don't want to in any way suggest that, well, it's $3.29. That's not important. We shouldn't care about it. We should. We absolutely should. We should have a system to make sure we're getting value for that 329. But I do think it's, again, important to think about how's the system working as a whole. And as we think about cost containment, how much do we want to focus the entire discussion on medicines versus thinking about how the system works as a whole? We also took a look here at new medicines specifically. And new medicines here are defined as medicines that were launched over the prior 5 years. And this is data from IMS Health. And there is a little bit of a sense in many discussions that a manufacturer gets FDA approval for a medicine. Again, you don't get FDA approval until you demonstrate through trials that you have a safe and effective medicine, similar standard for biologics. But you ultimately get the medicine on the market. There's a little bit of a sense that, well, basically the manufacturer can just sell it and, it just goes out the pharmacy like hotcakes. And while there certainly are a few cases like that, they're not the norm. And what we're showing here is that in 2014, for instance, which is the highest year here, about 1/3% of total national health spending went to medicines that had been launched over the prior 5 years. I think that there's actually a high bar to get uptake of new medicines. That high bar is created by the fact that we have enormous utilization of generics. We have a very empowered payer sector. We have competition between brand medicines, and you need to show something really valuable in order to get uptake of your medicine. There were questions about adherence earlier. There's data out there showing better adherence yields savings on medicines. And in fact, medicines are the only major category of services in the healthcare system that the Congressional Budget Office has adopted a scoring rule for, in which if a government initiative is going to increase the use of medicines, they count how much spending will increase. But then they actually also look at, they have a factor now for saying it's actually going to save money in the rest of the system, and they offset that against the increased cost. There isn't any other category of healthcare services that the Congressional Budget Office adopts that rule for. We also have significant opportunities for further savings. Again, this is data from IMS Health, a report that they issued in which they estimate better use of medicines, which is broken out in the categories you see on the slide, could eliminate up to $213 billion in U.S. healthcare costs annually, which is about 8% of total health spending in the United States. Non-adherence is the number one item, a difficult, complex issue. There are no cookie-cutter solutions to it. But, the fact is, we actually know how to treat. We know that we have effective treatments for people. They're not being used, and their health declines as a result. So having a focus on how we make progress against that goal could pay enormous health benefits as well as paying economic benefits. And then we have medication errors, suboptimal prescribing, and it all adds up to a very large number. I'll note that I mentioned I'd come back to HIV/AIDS. So in 1989, HIV/AIDS, as you can see from this news clip, was viewed as likely to be crushing the medical system. That's the quote from the director of the Division of AIDS at the National Institute for Allergy and Infectious Diseases at NIH. Right, we've got to get our act together because the medical system is going to be crushed in 2 years. Of course, some things happened, and we came up with treatments that dramatically improved the lives and increased the length of lives and increased the health status of patients with HIV. And here we have a quote from, a very recent quote from an Aetna physician saying, "We used to think HIV costs would overwhelm us, but we figured it out and let drug development progress." And I think that there's something important to take away from that as we hear claims today about where the system is going. So I'm going to turn to the prescription drug life cycle very briefly, which I think is particularly important to understand because it is a unique cost containment factor that exists in the United States. It applies only to medicines. We don't have anything like it in the rest of the healthcare system to hold costs down. So here from the government's Consumer Price Index, growth in retail prescription medicine prices has been in line with other healthcare prices. You see the prescription medicines line is just below all medical costs if you look at the decade back from 2015 to 2005. Now, that doesn't mean individual medicines are on that line. It means that a market basket of medicines is on that line. And that's made up of a market basket of brand medicines and a market basket of generic medicines. And I think that that's the right way to look at it because we have explicit public policy in the United States adopted in 1984, the Hatch-Waxman Act, to try to get both cost containment and innovation through a regime that would encourage the development of generic drugs while continuing to reward the development of innovative drugs. That's the retail medicines. Here's the non-retail medicines. This is a pretty good proxy for the non-retail medicines. Medicare Part B, which are the medicines that are infused or physician administered. And what we have here is that, again, average price growth in Medicare Part B for medicines has been less than medical inflation. And again, it's because it's that market basket of medicines. So how do we do this? Approximately 9 out of every 10 prescriptions in the United States is filled with a generic. The payers have gotten very good at maximizing generic use rates. They create strong incentives for people to use generics. And they get enormous savings as a result. Some people think that that's an issue that is past, that we're not going to continue to get savings. In fact, IMS Health, again, which does projections of this issue, projects that from 2016 through 2020, we're going to get $93 billion of brand medicines converted to generics and with very sharp price drops. And that projection doesn't even include biosimilars, which are now beginning to come to the market. When you add in the biosimilars, which is a new and developing market, the number will be quite a bit higher. So how does the life cycle work? Here you see the cost of the brand medicine and what happened to that medicine as it went generic. And in each instance you see enormous reductions. We really don't see that in other areas of healthcare, and this is part of what makes medicines overall affordable. It creates room for funding continued advances. It creates room for funding the innovative medicines that are the next step in improving care. Here you see just another cut at what I was showing you earlier. So if you look at the daily cost of the top 10 therapeutic classes most commonly used by Medicare Part D enrollees in 2006, and you go forward to roughly today, you see we dropped from about $1.50 to 47 cents. And that takes account of all of the movement of brand drugs to generic, new brands coming into the market, and so forth. So we've dropped by about 2/3 over 10 years. Again, a pretty unique result in healthcare. And I couldn't find a way to make this slide attractive or appealing, but I really like it, so I threw it in anyway. This comes from a group of Harvard researchers, including Hayden Huskamp, who does a lot of work on prescription medicines. And I like it so much I'm going to read it, even though you could do the same. Despite bringing breakthrough medicines to market, pharmaceutical companies incurred criticism during the 90s and early 2000s because of high prices of many drugs. We argue that the benefits of pharmaceuticals should be evaluated in a dynamic context that extends beyond the patent expiration date. Now that numerous patents have expired, generic medications exist in many important classes. Consumers reap the benefit of past innovation for years to come. We estimate that across 19 molecules whose patents expired from 2005 to 2009, between $193 billion and $436 billion will transfer to consumers over 10 to 20 years due to the patent expiration. This suggests that while prices were high during the patent period, creating an incentive for innovation, the transfers to consumers after patent expiration are significant, which is how the patent system is designed to function. So you can see why I like that. If anybody missed it, that is, these researchers, I don't believe had any industry relationship, but I've taken their work, and that is part of what I have come to believe, and so part of what you're seeing there is me giving you the industry perspective. Just to kind of go back to the point that this system is unique in medicines. If you look at percutaneous coronary angioplasty, I hope I said that correctly. I can't even say the names of the generic names of medicines correctly, so stuff outside my field I have an even less chance of getting right. But you all are many of you are clinical people, so you know what I'm talking about. We look at the change in cost between 2005 and 2013, and you see it's a pretty significant increase. You look at atorvastatin, otherwise known as Lipitor, where the overwhelming majority, almost 100%, is now used in the generic form. And you see we went from $2.13 a day to about 15 cents a day in 2014. Turning now to competition. I already made the point earlier that we have very, very large, powerful, aggressive purchasers. I think one of the biggest myths of this debate that occurs around medicines is that there isn't negotiation and so forth. We have 3 companies that now account for 75% and growing market share, and they're all focused exclusively on buying medicines and trying to drive down the cost as much as they can. That's their job. They're not buying other things. They're not general purpose agents. They're focused exclusively on medicines. That's why they're called pharmacy benefit managers. And they use a wide array of tools. Professor Danson already talked about many of these, so I won't go into them. I'll add that we actually are seeing these tools increasingly. We are seeing these tools increasingly used outside the retail pharmacy setting for those physician-administered medicines. They actually they accomplish a lot of their mission. These are just a couple of news clippings. There are many, many more out there. So Big Pharma's foe, and I believe that article was about Express Scripts, which is the biggest pharmacy benefit manager in the United States, takes victory lap as drug price increases slow. Price inflation-based rebates top $100 million a year for Express Scripts clients. And I mentioned earlier, CVS said last year they brought down drug spending growth to 5%. And we've talked a little bit about hepatitis C, but I just want to take you back to the atmosphere that it sort of encompassed much of the discussion about hepatitis C. So early in the discussion, we were hearing that this drug will break the country. Sounds a lot like what we were hearing about HIV. It'll make pharmacy benefits no longer sustainable. That was from Express Scripts. So they actually went out and negotiated as the second medicine came to the market, and they had some different things to say than what they were saying previously. The price is sufficiently low that we can go to our clients and say that they can treat every patient with hepatitis C. Another PBM, we were receiving market-leading rates from both companies. Neither company wanted to be left off the formulary, so they actually decided to cover both. And you see, similar quotes. I'll note, I don't have a slide on it, but we had a very similar situation around the PCSK9s, the important new class of drugs that actually lowers cholesterol for people who have super high rates and certain, family history and so forth, and people for whom statins don't work. And there were studies put out by the PBMs and so forth saying that the PCSK9s themselves are going to generate $150 billion a year of additional healthcare spending. That would be about a 50% increase in everything we spend on medicines. And there were actual studies out there that you can pull up in which they say that's what the PCSK9s are going to cost the system. If you look at what happened after they negotiated their deal, and two came to the market almost simultaneously, they say, oh, it's going to be a lot less than that, and it's actually going to be far less than we had previously thought. So I think that as you hear a lot of claims, I think it's important to remember the history and recognize that there are mechanisms in the market that actually work to hold down costs. And we're also continuing to evolve those mechanisms, and pharma companies and their purchasers are exploring, for instance, performance-based contracting. There are some significant limitations on that, in that certain government rules can make it challenging. So we haven't talked, for instance, about Medicaid yet. We currently have probably 65 million or so Americans in Medicaid. Medicaid gets government defined prices for medicines, it's not widely recognized, but the rebate was extended to tens of millions of additional people through the Affordable Care Act. Previously, Medicaid managed care plans didn't get the rebate. By law, it was extended to the tens of millions of people there. Medicaid itself was expanded, and the amount of the rebate was increased significantly, or the minimum amount of the rebate. So there has been, I think, some growing recognition that the Medicaid rules, which require that Medicaid will always get the best price based on any single transaction, can sometimes make it challenging to do certain types of performance-based contracting that purchasers and manufacturers might want to do. For instance, if you said, well, we want to set something up where we don't get paid if somebody doesn't benefit from a medicine, well, that's the one sale that sets the best price for the whole country, including in Medicaid, including for people who do benefit from the medicine. So, there's a recognition, I think, that's been growing in some of the policy discussions that, that there are some distortions in the market. And I'll note that 340B would be another one. Currently, we haven't heard anything about it today, but currently about half of all hospital purchases of medicines, of their outpatient medicines, which includes their physician-administered medicines, go through the 340B program, which gets very, very deep discounts. And it applies to all patients, not just those who are uninsured. It applies to patients who have, United Healthcare or Blue Cross Blue Shield. Again, it sort of works in a similar way as a Medicaid rebate. And again, part of what we see happening is that there are very, very deep discounts, along with, including inflation caps, on the medicines, but then there are really no requirements that the patient necessarily benefit directly, and many hospitals, through 340B hospitals, choose to mark the price up very high rather than pass those discounts through. And we see the program expanding very, very rapidly, particularly as hospitals acquire physician practices. When they acquire a physician practice, say an oncology practice, they can then take those prescriptions that were previously commercial prescriptions, let's say for a Blue Cross patient, and convert them to 340B, where they get these extremely large discounts, and then they get the very significant markups. So there are some issues that they are looking at, like how's the 340B program working, and to what extent is it interfering with what would otherwise be more effective marketplace functions. Researchers like Rena Conti from, I think, University of Chicago have written quite a lot about this, so you can look at her work. So I'll just close by saying that I think that there is a positive agenda that we can get on in terms of cost containment, paying for value, and finding solutions to healthcare problems. You can go to Pharma's website, any of these links, and you'll see the kinds of positions they've taken, the kinds of suggestions they've offered to try to make progress on, the really hard work of making American healthcare better and more affordable. Thank you. answered everything. Ah, no, I didn't, okay.
One's a comment, the second a question. The first comment is that in thinking about the way, however, that hospitals set their pricing strategies versus the way that this happens from a PBM paying for a drug in a community pharmacy are much different, because in a community pharmacy-based setting, you have a product that is oftentimes viewed as a commodity with a fixed price, but an unlimited supply potentially of that product. So it's a little different scenario. And although I clearly have no strong understanding of economics, I'll make myself evident on that, sorry. Hospitals, on the other hand, are dealing with a largely personnel-based system where you don't have an exponential amount of resource available. And in fact, in certain disciplines may have a shortage of the professionals necessary to be able to provide the service. And general basic rules of economic supply and demand would say that we may have to pay more to have a specialized oncologist in a hospital, which by necessity would cause an increase to the cost of the hospital. So I guess I wonder, how do you reconcile? Because those are really, to me, they're apple and orange comparisons. They're not apples and apples.
Sorry, I keep so with the 340B program and dispensing through 340B hospitals, where again about half of all medicines purchased by hospitals are now through 340B. I think in cancer it's believed to be bumping 2/3. I think that we could spend a long time talking about 340B, its history, how it's working, how it's not working, and so forth. But let me give you this point from a study that came out of an organization called the Healthcare Cost Institute just a week or two ago. It's actually featured in some of the health policy newsletters that come around daily. It's featured today for some reason, even though it came out a couple weeks ago. So what they found was as hospitals consolidate physician practices, and as they bring physician practices in, each 1% increase in market share and I want to try to get this right, okay? I definitely want to get this right. Hang on one sec. Each 1% of market share increase led to, I'm sorry, I wrote it down and now I can't find it, like a 34% increase in the cost of medicines dispensed through the hospital. So what's happening is prices and utilization end up changing when those community oncologists end up moving out of their practice and become hospital employees or whatever. And I think this is something that's starting to attract a fair amount of attention. I think that one side of the argument is that there's really the change that's happening is a change in status from community oncologists to hospital-based, and as a result, we're seeing very different pricing and utilization.
So my second question really is about rebates and discounts.
Yes.
Which are really quite different, and the operation of it quite different.
Yes.
So rebates, and correct me if I'm wrong, rebates generally are paid to the PBM, most generally based upon volume-based purchasing and so forth. Discounts, on the other hand, are pricing that's provided directly from the manufacturer to the ultimate provider of that product, correct? So it's a little different. A discount logically might be more easily passed along to a consumer because the end recipient of the product is actually getting the discount, whereas a rebate is actually not going to the healthcare provider that's the end user. The rebate's actually going to the middle person, the PBM, that's in between that transaction.
So the rebate goes to, I think you're right. Typically the rebate goes to the PBM, and then a share of that gets passed along to the health plan, typically that the PBM is an agent of. Interestingly, by the way, when patient cost sharing amounts are set, it's typically based on sort of, let's call it the list price or gross price. When health plans set their cost sharing amounts, if they're using a co-insurance, if they're using a flat dollar fee, it doesn't really, matter. So even though the net price of the plan ultimately is far lower, the patient will pay, a co-insurance on a higher amount. But putting that aside, rebates come after the transaction, let's call it after the transaction at the pharmacy counter. There are a lot of different discounts, in the system. There's prompt pay discounts, right? And there are discounts to wholesalers and so forth. Something like 340B is basically set up more as a discounted price rather than as a rebate, whereas Medicaid is set up, differently. So there are a lot of different systems out there. And I think you're right that they have sort of different implications. Yes, sir.
So one of the things, I really enjoyed your talk, and the thing is that a lot of the data that you present is, you're sort of comparing this to the cost of healthcare in general. And that's an enormous pie. The problem is that, as like the first talk that we heard, people are experiencing real ethical problems.
Yes.
Okay, and
Yes.
I'm a pediatric neurologist. I don't do any IV, but Acthar gel, tetrabenazine.
Yeah.
This is predatory pricing.
Yeah.
What does pharma think about that?
Yeah, so, so as I mentioned earlier, there's there's been, sort of a class of situations, and specifically, Turing and Valiant have, obviously been very prominent, in which we've seen the kind of, really steep price increases that you just mentioned and that our first, speaker mentioned. As I said, we've identified, publicly those companies as, hedge funds masquerading as pharma companies, and recognize that there are, important steps, that need to be considered. So again, clearing out the generic backlog, something like 4,500 generic applications awaiting action. And then, assessing, are there, in these situations where you have these really small markets that aren't supporting, multiple generics and you get the kind of result you're talking about, are there incentives that need to be adopted so that you can bring, enough players to the table that you don't get that kind of result? Yes, sir.
In the last year or two, we've been seeing a number of drug shortages in our hospital and certainly all across the country. Most recently, morphine. And that's what I use a authorized agent-controlled analgesia pump with morphine. We can't get it. We can't get it until May. How does Big Pharma help explain why that happens?
Okay, this is not an issue that I know enough about to give you an intelligent answer, okay? I apologize, and I'm glad to follow up with you afterward. Give me a card, and I'll get back to you. But I am definitely not the subject matter expert on shortages, and whatever I say will be like a wild guess and probably wrong. Okay, sorry about that, yes.
When you mentioned biosimilars, you showed this chart with the savings from generics, and you said that this doesn't even include biosimilars. And pharma often makes the point that biosimilars are beginning to come. The reality with biosimilars is that the rules are being set up so there is no reason to expect savings anything like what we get out of generics, because in general, there's going to be the 12 years of data exclusivity instead of 5. There is going to be very limited availability of substitution at the pharmacy. In any case, most of these drugs are dispensed by physicians, and the rule will be ASP plus the 6% that's calculated on the originator, you know all the details. But it all adds up to, there is very little reason to expect that biosimilars will be giving much in the way of savings. They will be promoted as branded drugs, just like originator drugs, and that's one reason why the originator companies are producing that.
Yeah.
So what's farmer's official position, I guess, on what sort of savings we're going to get from.
Well, I mean, I don't think pharma has, sort of an official projection of what the savings are. I mean, we've noticed that there are, multiple projections out there. IMS just came out with some projections in, for 2016 to 2020 in the tens of billions range. There's, research from RAND that I think suggested 25 billion over a certain period, and there are, a number of other studies. So I don't think we have our own. Let me take a step back and just add an observation. The biosimilars market, I think, is going to have, it's not going to look, like, today's mature generic market. And I think it's widely understood that the process of, manufacturing a biosimilar and so forth means that the economics are going to be somewhat different. At the same time, I do believe that there are going to be significant savings. And I think that if in 1984, somebody had told Orrin Hatch and Henry Waxman that looking ahead to 2016, we're going to have 90% of all U.S. prescriptions dispensed as generics, probably everybody would have said, that's laughable. I think that the payers actually have a real incentive to drive biosimilar use. I think that some of the other changes that you highlighted in your presentation, where we're moving more to health systems that are using pathways and incentives to back up those pathways and so forth, are all likely to play into having a real biosimilar market under which biosimilars are going to be used. I can't tell you, I think it's, X or 2X or 3X, but I think it's going to make, I think it will be, a very noticeable, vibrant portion of the market. Yes, sir.
So pharma, PHRMA.
Yeah.
Is there a business and trade organization?
We are, yes, I should say that. So we are the trade organization of innovator pharmaceutical and biotech companies. So our members, include, many names that you're familiar with.
Do they include Turing and?
No.
Raymond?
No.
So they're not members of it. So you couldn't police them or kick them out of the club for not asking?
Well, we could. They are not and have never been members to my knowledge. The one other thing I will say is that it is important to recognize that trade associations are associations of competitors. They are permitted to work, competing companies are permitted to work together in the trade association around members of public policy, but they're absolutely forbidden to, collude about things going on in the marketplace. So, that's where things stand. But no, they're not members.
So you as an organization can make claims about them, and it may or may not ring a bell. You may say they're a hedge fund, masquerading as a pharmaceutical business.
So, well, we've been very clear. Go to the website, take a look, see what people say. I think that there's a strongly held view that that these are not the kinds of companies that are making the kind of contribution that I think that the members of Pharma do make. Sorry.
You mentioned that there are mechanisms in the market to control maybe reduce prices.
Mm-hmm.
I think you touched on some, but could you enunciate those? And also, if you think there are successful mechanisms in the Affordable Care Act to control and bring down prices.
All right. So market mechanisms include medicines in a lot of respects are purchased very differently than the rest of healthcare. So the vast majority of medicines are purchased, as I mentioned earlier, by a small handful of companies. All of those companies sort of do what they can to control access to medicines, and because they control access, what kind of insurance coverage it's going to be, what kind of prior authorization, whether it's going to be step, whether it's going to be step therapy and so forth. They use that control over access to medicines to extract discounts. And I mean that in sort of the broad term, not technically, but savings, which may come in the form of rebates, and may come in other forms. What we have, we have the tiered formularies, which is really a much more aggressive type of benefit structure than we have for the rest of healthcare. We also tend to have pretty high out-of-pocket costs for medicines. If you look at it as a percentage of the total cost of medicine, of total costs, for hospitals, out-of-pocket costs come out to be about 5%. For medicines, they come out to be in aggregate about 20%. So they're using, their control over the benefit, their control over, the formulary and so forth to negotiate savings and discounts. You also have drugs that you have like physician-administered drugs, for instance, that are often in the medical benefit, and they're using a couple of things. I mean, they've historically used prior authorization and a number of things to go along with that. Specific variations on prior authorization. But you are also seeing, because you're getting to significant, you're increasingly seeing competition. You're also seeing those medicines being increasingly subject to some of the same kinds of tactics that you see in the retail medicine side. I should add that that the payers out there, they do all of the analytics. They do the type of analytics that that have been discussed, right? They're big, sophisticated purchasers. They do the cost effectiveness, analytics and so forth, and that's part of their decision-making process. Now, ultimately there's a negotiation, that occurs, and those analytics are one of the things that's going to inform, that negotiation.
Well, PBMs have been mentioned several times, so I want to offer another point of view than the pharma point of view. There's a literature going back 15 or 20 years about PBMs being double agents, that they come to the employer and say, this is a complicated field, give us a carve-out contract and we will save you money, and then turn to the companies and say, we've got all these employers with tens of hundreds of thousands of employees signed up, and what kind of a deal can we cut to increase market share on the high market drugs? So I just want to note that, so it would be a great area for students to look into, because no other country has PBMs. No other country thinks PBMs are needed. They are one of the middlemen creations of the American healthcare system. And that's tied into the comment about rebates. So what is now called a rebate, it's a shift in English. It used to be called a kickback. And there were anti-kickback laws. And they're now politely called rebates, but they are in effect kickbacks. If you want to know more about the pharmaceutical story that's not from pharma, you can look at www.pharmamyths.net, and you'll see a number of the major points addressed in free referenced journal articles about the sort of created story by the industry and the ways in which it doesn't really square. And one of those is...
Can I comment?
Yeah. Well, I'd like to say one more.
And actually, I need to jump in just because the time for this is over for this session, but we can take this right into the panel discussion. Because I know some students probably have to leave if it's 1:45, but then we're going to have new students coming in. So I hate to interrupt, but would that be okay just to start the panel discussion in about 2 or 3 minutes?
Sure.
We'll just bring some chairs up and thank you.
I'm You know, we had John Majors here, back when he was prime minister. Someone asked him a question, he didn't exactly say Parliament, and he said they're different names. Frog bottom. And he said, I was going to say Mount Frog's bottom. He said, we all came from a different name.
Yes, I did know your wife because freshman year, you were in Hartsfield College. I was in a different.
That's where I've seen this stuff.
Yes, I know your wife. I haven't seen her since freshman year. I remember that, yes. Okay. All right, that's
Then it had a death.
all right. Oh, okay.
He was not there. I saw he wasn't Brad Reed, I saw him.
You're welcome.
So Brad said, that was so-and-so. They love you. They knew him. Brad had a lot of credit. I always hear it, and I'm thinking that's what we kept running it's fine. I ran out of gas so quickly. I think so, yeah.
Okay, thank you.
I know, it's always flying out no matter where I'm going. Whether I'm retired or not.
Excuse me, I think we'd like to go ahead and get started. Let me just say, I just really appreciate all of you being here. Appreciate our speakers and medalists and panelists and fellows. And I'm Lori Bateman, by the way, the program manager, so you may have received emails from me. And I also just want to say a special thank you to Elena Andrews, and she's probably out there, but I know you received a lot of emails from her, but she has helped out with this conference for years, and she's so very helpful to make this conference run smoothly. I just want to remind everyone that they have a couple of evaluation forms in their packet, not students, but everyone else. If you could fill those out along with the post-test, that would be really great. And so I can collect those at the end of the conference. There's 2 evaluations, and I'm sorry about that, but if you can complete both, we'd really appreciate it. And if you're a nurse, there's another evaluation, and if you don't have that, can you raise your hand? Okay. Okay, great. Well, I will turn it over to Amy Bressinger then.
Before we move on to the last session of the day, Pharma sponsored Dr. Smith's talk, but they did not sponsor today's conference. So I was asked to clarify that before we move on. We've come to the time in the program today for our panel discussion about ethics and policy regarding drug pricing in our country. My name is Amy Bressinger, and I'm on faculty at the McWhorter School of Pharmacy here at Stanford, and I will be introducing our panelists and moderating the session. Our panelists are our Pellegrino Medal awardees, Dr. Patricia Danzen from the Wharton School of University of Pennsylvania, Dr. Donald Light from the Rowan School of Osteopathic Medicine, as well as Dr. Dennis Sansom, who is chair of the Department of Philosophy here at Stanford, Dr. Jack Nelson from the Cumberland School of Law here at Stanford, Dr. Tom Puddle from the Division of Internal Medicine at the University of Alabama at Birmingham School of Medicine, and Dr. Leon Doerr of the Division of Child Neurology, Department of Pediatrics, University of Alabama at Birmingham School of Medicine, and Rick Smith, who is the past Executive Vice President for Policy and Research at the Pharmaceutical Research and Manufacturers of America, from whom we just heard. So perhaps a good way to start our conversation would be to pick up where we just left off. So, Dr. Light, did you want to finish that point that you started?
I'm not sure I remember what the last one was, except that if you want to see, if you want to get a, thank you, if you want to get another point of view, PharmaMyth.net has a small collection of the rather large independent literature that assesses point by point a number of the key parts of the industry's narrative and shows the ways in which they're true. So anyone who wants to get another point of view, it's out there. But pharma, as a huge trade organization, generates a lot of the alleged facts that then appear in articles by science writers and journalists and TV people. Their huge communication network is the major way in which they construct the industry story for news channels and discussion channels and magazines and so forth, as do other trade associations.
So, look, I don't think it's productive to respond to the ad hominem stuff, so I'll just let that aside. But, let's go back to the substantive points that are being discussed. And I would say, look, go to the pharma website. We have a sister organization, Biotechnology Industry Organization. Go to their website. My deck had, the links for pharma. Look, read the stuff. Make an assessment, test it, pressure test it. I welcome it. I'm glad to talk with y'all. I mean, because I actually think that there's a darn good story, and I think it's actually to the detriment of everyone who's trying to grapple with healthcare issues. That story actually isn't out there as broadly and deeply as it should be, and I think it's a strong fact-based story. So again, I welcome people going to the website, pressure test it. My table mate back there said she was going through the sites, and I think that's great, and everybody should. Beyond that, going back to the earlier point of PBMs. First, let me make one thing clear. Pharma as an association, is not out there. Promoting, PBMs. We're not, I think most people would find it to be, most people who sort of observe this stuff would find it to be amusing, to put that thought out there. There's a lot of pulling and hauling in the market, as there should be. That's part of what happens in markets. But, I will say, there are certainly things that PBMs do that, as an industry, we think is not necessarily, the best course to be taking. But, putting that aside, they are a significant participant in the market. And, I guess the question I have is, how do we get to 90% generic use, which is the highest of any, country, if this is, all some kind of, fake system. There isn't a lot of disagreement. We're at about 90% use, give or take a couple of percentage points of generics, because we have a system that's been optimized to steer people away from brand drugs to generics. I think the proof's in the pudding.
So our format for this session is that feel free to ask some questions of our panelists, and they can feel free to ask some questions of each other, and we'll continue our great dialogue. There's a tremendous amount of experience and expertise on this panel, so we look forward to continuing the conversation.
Can I just add that there's a tremendous amount of expertise with our moderator. I've read your work, I just realized who you are, and I'm glad to meet you.
First question.
I'd like to ask, what is the history of the PBMs? When and how and all that?
Is that coming from me?
Yes.
Okay, well, I am not a, so actually before I was at Pharma, where I started in 2001 to run the policy shop. I spent 6 years at the organization now known as AHIP. It had a different name back then. Organizations that I work for and leave tend to change their name. I think they're trying to hide the connection. So I did have significant experience from the payer side. I ran the policy shop at AHIP, America's Health Insurance Plans, which represents the health plan part of the world. So I have a broad kind of base there. I'm not a PBM expert in terms of their history, but I will say that so if you go back probably into the 70s and 80s, very often you didn't have any kind of drug benefit attached to health insurance. Health insurance kind of grew up, one side was covering physician services, the other side was covering hospital services. Because when health insurance started, drugs weren't really a big deal, right? They weren't, you didn't have the armamentarium you have today as clinicians to treat patients. And that's also why, drugs, I think, weren't part of Medicare, because in 1965, they really weren't that big a part of healthcare. Starting in sort of the, probably, late 70s beginning, and then picking up steam in the 80s and through the 80s, you had much more coverage of prescription medicines being added to health insurance. And because medicines were becoming much more important, there was a recognition that to manage people's conditions, you want to get them using their medicines and so forth. I think it was about that time that the PBM industry, it was probably in the early mid 80s. And if anybody here has better information, please correct me, because I'm not sure I have this exactly right. But my best understanding would be you had companies that specialize in purchasing prescription medicines start to grow up. And initially you had a lot of competitors out in the market. Some of them actually were companies that started with pharmaceutical companies that were ultimately spun off. And then you've had tremendous industry consolidation since then, such that we now have 3 companies making up 75 to 80% of the market. But I'm not a better historian than that, and I think we might have a much more knowledgeable historian than me.
So I would just add to that one of the things that PBMs added, and this was back in the mid-90s, or early to mid-90s that they were created, they took advantage of the new technology at the time to enable them to give beneficiaries, the enrollees, a smart card that could be swiped at the pharmacy so that the eligibility for reimbursement could be validated real-time online. The patient only had to pay the co-payment, and knowing that the drug was on formulary, the payment could then come from the payer, the health plan. And at that point in time, it's hard for, I'm sure, some people to actually imagine that there was a day before you could walk in and just swipe what you've covered. But it was a real economies of scale play. The PBMs were the companies that had the electronic links to all the pharmacies. And so for a health plan, it was much better to contract with a PBM than for themselves to try to contract with all the pharmacies in the area. They would contract with a PBM that had all those links. And the PBM was playing 2 roles, as was mentioned earlier this morning. They were not only negotiating price discounts from the drug manufacturers in return for preferred formulary position, but also squeezing the pharmacy margins and getting significant savings on the discounting fees that pharmacies added. And it was an early study that looked at where are the savings coming from that said about half of the savings is coming from both of those things. And I think what is interesting, for all that PBMs seem to be a very flawed sort of organization and just add costs, if you look at what's happened, some of the large health plans, like WellPoint, for example, tried to bring their own pharmacy benefit management in-house, and in the end, ended up outsourcing again their payment for drugs because the PBMs could do it more efficiently than they could. They still do some part of the PBM function in-house, but basically the PBMs have not been driven out of the market by large health plans managing everything in-house. So for all the perversities of PBMs, they do seem to have some raison d'etre in the marketplace.
Yes, sir.
Thanks to the beauty of Google, the first pharmacy benefit management company was established in 1968. It was called Pharmaceutical Card System, Inc., later Advanced PCS. It originated in 1968 with the invention of the plastic benefit card. And by the 70s, they served as fiscal intermediaries by adjudicating prescription drug claims by paper, and then in the 80s, electronically. And by the late 80s, they were a major force as healthcare and prescription costs were escalating.
Yes.
I have a question for the panel. You all may wish to reply to this, but PBMs, if you look at the salaries of the CEOs, they're pretty enormous, well over $1 million oftentimes for their compensation packages, and sometimes can go way beyond that. We live in a free market, free enterprise system where there are shareholders of corporations and they expect a return on their investment and so forth and so on. But we also live in a society today that can ill afford health care for the poorest of our citizens. And this state in particular, Alabama, is faced with a budget crisis in which the state is going to have to make a decision before October as to whether or not prescription drugs will continue to be a covered benefit for Medicare beneficiaries. How do you reconcile ethically the provision of medicines to people who need them for life-sustaining services and the profit making of PBMs who may act as a fiscal intermediary on behalf of a public entity using taxpayer dollars? And that's really the scenario we'll be in with the RCOs in our state. So just a comment on that from an ethics standpoint.
Well, wait, because I was just going to add to the question. That's the way out. No, I mean, I think the question is, and I get back to my last question, Dr. Light brought up the point that we're the only country in the world where people go bankrupt for health care. Now, I don't know the answer of how much of bankruptcy is due to drug costs. I mean, that would be important to sort of factor in. But the question keeps coming up, do we have an ethical system? It may be legal, it may work, but is it an ethical system? And that's sort of part of the conference. It's something we ought to talk about. I agree. Your turn.
Well, I certainly don't want to defend the Alabama State Legislature. Their approach to health policy, which doesn't make any sense at all. Obviously, we should have expanded Medicaid. It's foolish not to do it. But I can see a role for pharmacy benefit managers, even in the RCOs, if there's added value, if they do something worthwhile and improve quality of care or contribute to cost-effective use of drugs. The fact that they're making a profit doesn't bother them if they're providing something of value.
My understanding is that actually Medicaid is one of the payers that doesn't use PBMs.
Currently, that's the case, but that may change. That may change.
We've got this coordinated care, regional care organization.
Yeah, no, I understand.
It's kind of a strange deal,
But
I don't know.
I think those RCOs, like the the Medicaid managed care organizations in other states, will probably manage their own costs. But I don't know.
I'd like to broaden the discussion out to medical impoverization. So the United States is the only advanced capitalist country where becoming poor through medical care is actually official policy. Time and again, Congress has passed bills that essentially allow impoverishment of seriously ill people. This is not allowed in any other advanced capitalist country that I know of.
And in this more recent era, where co-payments have gone from being flat amounts like $5, $10, $40, $50, to percentages of especially the very high-priced drugs, according to the oncologists that I co-author with and talk to, impoverishment through prescription drugs has become far more substantial than it was before. And according to the New York Times articles that I read, the ways in which the private insurance companies for which the ACA was designed, it was designed to provide large public funding to enable millions more people to afford health insurance. These companies are structuring premiums at the front end and co-payments and caps at the back end in such a way that millions of people aren't even bothering to go to the ACA policies because they can't afford them.
Despite that, as bad as it is, I hate to think what the Republicans will do if they come to the White House next year and take over Congress as well, totally.
I think that might be their greatest fear, actually. Honestly, then you're held completely responsible if things go bad.
I would agree with the comment that it just, something seems obviously wrong to have certain policies, whether overtly intending this or inconsequentially intending this, have a portion of our society that become impoverished because of health care. And what seems so just obviously wrong about that is that I do think that health care is a basic social good that all people should have access to. We do that with education. We think all people should have access to education. We do that with police protection, fire protection, all these things we deem to be essential for a people to flourish in a society. And I would say since health and health care has to do with, in a sense, our most intimate possession, and that is our bodily existence, then it just, to me, seems ethically obvious that we should be doing things to do that. Now, the big question is how. I mean, we can always live in tension with our ethics, but the bigger problem is how to apply it in a way in which it can work. A comment was made earlier about the market, and one of the ways in which people understand that word, the market, is whatever it will bear. That is, a market is that system that will, whatever it bears. I think that's a very sort of unsatisfactory answer of what the word market wants to do. The market wants to talk, in a way, describe how people interact with one another based upon what they need and what can be given to them. That's what a market is. Now, this may all sound rather 30,000 feet above all this discussion, but you can think of a market in two ways. On one hand, there's what you could call just the abstract market. That is, we have this kind of sense that things are going to settle out there based upon whatever it will bear. But in reality, that's not the case. It's those people who are rich enough, powerful enough, privileged enough, whatever, that end up determining the prices of things that the market can bear. In healthcare, it seems to me that that's pretty well determined by, well, this is what Patricia was bringing up earlier when she was lamenting the sort of intractable complexity of our healthcare system, that's determined by people, the government, insurance, large industries, that are not really involved with the person who wants that particular health care. Prices are being determined by those who do not specifically want it and thus can pay for it. Now, I don't think that's a true sense of market, because a lot of portion of our society is left out of all that. And that sense of the market gives health care to those who are powerful enough, rich enough to afford it, or have some means to do that. And that price hence becomes even more escalated for that reason. And hence, I think we ought to really reconsider what we mean by the market. All people are involved because we are a society. All of us are involved in the various institutions and social relationships, ranging from education to defense and commerce and so on. aimed that we as a society can flourish and experience well-being. And some way or another, like I said, it's a rather abstract notion, but we need to think of the market as including those people who can experience impoverishment as well, because they are part of that system. They shouldn't be left out of it. Anyone else?
It's my turn. So did you want to?
The high deductibles that the ACA has put into place are an attempt to make the policies which are sold under the ACA financially viable, given the fairly generous mandates which those policies have met. We have a very expensive healthcare system. Hospitals and physicians make more in the United States than elsewhere. And that's for very complex historical reasons. It seems to me that what the ACA did was not to mess with the incomes of providers very much, but merely to figure out a way for low-income people to be able to buy insurance, because A, there would be policies that would conform to these mandates, and low-income people would be generously subsidized, arguably not generously enough, to be able to buy them. So if you do nothing about the cost problem, but simply fix the access problem, I mean, it seems to me that this is a very natural kind of consequence. And a lot of people on the right say, well, if people have more skin in the game, if they're paying their own money, well, that's going to be a way for eventually more competition on the provider side to creep in. But the provider side still seems very fixed. I mean, it's kind of like New York taxis. We all have our skin in the game when we pay the taxi, but if there's only so many medallions and so many taxi cabs, then having skin in the game is not going to fix things. And only an innovator like Uber coming in and having a completely new model might make a difference. So it seems to me that if providers are forced to repackage and reprice their services, that may be a way forward for real competition to actually happen and prices to begin to come down. But it has to happen on the provider side. I mean, the provider's price fixing needs to be unraveled.
Dr. Smith, did you have a comment about that? Sure.
First, I want to know, I am only a doctor, if I am at all, by virtue of a JD. I don't think that counts. But, I'm also, there are a lot of things I'm not a doctor. I'm also definitely, not a philosopher, ethicist. My son actually happens to be a first-year PhD candidate in philosophy, but he got that from his mom, not from me. I'll just add a few points. Number one, I think that there's widespread agreement that people shouldn't have to go bankrupt to get medical care that they need. I think that there's always challenges around the specific means, but I think that there's widespread agreement that shouldn't be an outcome. In the biopharma sector, we do have patient assistance programs that provide usually free medicines to people who don't have insurance, low income, so forth. One point. And I'm not saying that that's a comprehensive solution. I'm saying it's one part of a safety net. And in the industry, there are programs out there that are also intended to be safety net that haven't really been used that way. Perhaps it could be better repurposed as part of the safety net, like the 340B program I mentioned earlier. But I want to add another dimension to the ethical equation, which is we need to worry about now, and we need to do things to take care of now. But there's also tomorrow. There is a tension to some degree between today and tomorrow. It's, you know, it's something that I think is always in the process of being balanced and being worked through, and there's no, you know, there's no universal answer for all time. But, you know, it's been noted that, you know, you can always, you know, we could say, you know, all medicine shall be a penny a pill. And you would immediately make, you know, today better off, you know, for everybody. I think most people, maybe not everybody, but I think most people would accept that that's not likely to yield a lot of progress, for instance, on the president's moonshot, or you know, the many other, you know, unmet needs. So I'm not saying I have a perfect answer, but I am just adding that there is, you know, if you accept that there is any need to invest, and that there's any relationship between, you know, how the system operates and the capacity to invest, that's another factor that adds to the difficulty that I think, you know, all stakeholders in the system face and policymakers face as they, you know, work through what the, you know, what the right regime is.
Other questions?
I would like to ask on the, when we look at Medicare Part D in rural communities and where we're from a rural community, as we look that there are a lot of policies and there are a lot of programs, but when you come into the rural community, they don't serve our community. And so we may look at there may be 52 different programs in that serve the state of Alabama. But when you come down to Perry County, when we start looking at serve, there's only 25 that we look at when we start coming to looking at it from the prescription point of view. Then we start looking at it from the health standpoint, there's only 2 programs. And it costs more. The co-pays are more. And so, you know, and we're in a rural community where the individuals, they're living in poverty and they're struggling. So what would be, do y'all have any idea if there may be something that, a way that something can help our community? And some ideas of ways that there may be some help coming.
Well, I would just say that it's really unfortunate that Alabama is one of the states that has not adopted the Medicaid expansion, which under the ACA was supposed to be the way that affordable insurance and affordable health care would reach the population that is below the poverty line. And because, as we all know, because that part of the ACA was deemed optional for individual states, several states have still not adopted that expansion, and that population that under the ACA was supposed to be covered by Medicaid expansion is not eligible for the income-based subsidies that would enable those people to buy insurance through the exchanges. So the unfortunate people who are below the poverty line in states that haven't adopted Medicaid expansion have seen none of the benefits of the ACA. And the rural population in Alabama is precisely one of those population groups. And so, you know, I think at some point there will be some way forward for those very important segments of the population in those states that have chosen not to go with the Medicaid expansion. But that is a very serious shortfall that wasn't intended by the original legislation, but is the unfortunate fallout of that ruling by the Supreme Court.
I think that's about the best answer possible. And what it implies ethically in terms of distributive justice is that all of us here in this room and the people we know can organize the churches and affiliated associations, as maybe perhaps even the university, to advocate for Alabama taking the Medicaid expansion on behalf of the injustices to the rural parts of the state. And this is a moral, this could be a moral campaign, and then you will benefit from this meeting.
Good thought.
Question over here?
Yes, my question was also directed primarily to Dr. Danson, but I'm open for any commentary. You previously mentioned barriers to the adoption of biosimilar usage. How can policymakers act or alternatively back off in order to encourage efficient use of biosimilars or other potentially cost-saving medications, medical devices, or other products, goods, and services?
In the US, we have this unfortunate dichotomy between chemical-based drugs, which get 5 years of data exclusivity for the original manufacturer's clinical data, whereas biologics get 12 years of data exclusivity. What that means in practice is that generics may enter the market as quickly as 7 years from when a new chemical drug was launched, but it will take at least 12 years before a biosimilar would get to market. So that's number one. We have this difference in the data exclusivity period, which is the period during which a follow-on product cannot reference the original clinical trial data of the originator to come to market in a cheaper way. Personally, I think 5 years is too short. I think 12 years is too long. That the European Union, which has gone with 10 years for all drugs, regardless of whether they're chemical or biologic, is probably a better place. But that would, if we were to change that, it would get biosimilars to market more quickly. The second thing is that, granted, biologics are more complex in manufacturing, and so it's potentially more difficult to validate that a follow-on product, a biosimilar, is exactly the same efficacy as the originator product. With chemical drugs, it's relatively easy to demonstrate that the generic company just shows bioequivalence and chemical equivalence, and they don't have to do new clinical trials. However, the clinical pathway and the clinical trials that we require in the US for biologics are very extensive. And the result is it's very expensive to come to market as a biosimilar, and relatively few have even tried. We only have 2 on the market. There are many already on the market in Europe. The third thing is the reimbursement for biosimilars. And I won't go into the complexity of that, but suffice to say that at the moment, there is no financial incentive for anybody to choose the biosimilar rather than the originator. Whereas with the chemical drugs, the pharmacy makes the decision, and the pharmacies make a lot more money out of using generics and out of using originators, and they're the ones that have really pushed the shift to generics. Now, that is possible because we've allowed the pharmacies to substitute generics for originators for chemical drugs because we can be confident they are the same thing. So there's a real scientific difficulty here. However, we in the US are erring on the side of making it very hard and very expensive for biosimilars to get to market, and much slower. And the European Union has gone further in that direction and has more extensive adoption of biosimilars already.
How do the Europeans test biosimilars sufficiently to be confident to allow them on the market without such great expense?
I am not enough of a scientist to say exactly what is required in terms of demonstrating the various equivalences, but I certainly am aware that it's not as costly. There are many already on the market. They do leave to the individual countries the decision as to whether or not a biosimilar will be treated as substitutable or not. and different countries have gone and made different decisions, and it depends. Again, it's a mistake to treat all biologics the same. Some are relatively simple, some are very complex. And so the expectation is we could go more quickly towards substitutability on the simple ones and take longer before we move to substitutability on the more complex ones. But hopefully, if there is some willingness to look at the actual data on use of the biosimilars in Europe, that could be used in the US as evidence of equivalence or not. But that so far is not part of the approval.
In terms of the 12-year rule, it's a good example of the product of well-documented intensive lobbying by the Congress of Lobbyists that's twice the size of the US Congress and led by PhRMA, the trade association. So the 12-year data exclusivity legislation and the lobbying for it is one of the products of the industry's trade association. Another one was they're putting into place the wording that prohibits Medicare from negotiating lower prices. So these things that where we say, well, it's the law, or Congress decided that, are the products in often quite closely documented of very heavy intensive lobbying by the industry for its own profit, increased profit.
It is true that in political processes, politics happens, so we're agreed. And the industry, very forthrightly, very publicly, supported 12 years of data exclusivity. Previously, there was no pathway to biosimilars at all, so data exclusivity was essentially unlimited. And ultimately, based on a lot of analytics, we thought that 12 years was the right length. By the way, nobody ever suggested Dr. Danzen's point about going to a uniform amount with actually increasing data exclusivity for the small molecules. But I'll add that there was one bipartisan provision of the Affordable Care Act because the pathway to biosimilars was created in the Affordable Care Act. And I think this is accurate, that the one and only provision which obtained strong bipartisan support was the provision which set the rules for the introduction of biosimilars, including data exclusivity. And I think that that was a result of I think it was a result of persuading people that the argument was correct and that this was the right compromise. Let me add, because we've kind of come back to it, this issue about the language prohibiting Medicare from compromising, from negotiating. So I actually, I remember being stunned when this issue first came up, because if you trace the history of this language, it actually started in Bill Clinton's kind of precursor to the Medicare prescription drug benefit. And I think that over the years it's created a lot of misunderstanding. So let me just repeat what I mentioned earlier. So in Medicare Part D, we have a system in which private plans compete on premiums and so forth. And manufacturers then compete for access to that market that is created by the private plans operating under a very comprehensive set of rules set by Medicare. So there is a provision that says that the Medicare program may not interfere in the negotiations that occur between manufacturers and plans, and the Part D plans, or between manufacturers or between Part D plans and pharmacies, and that the government may not establish a single formulary or price structure. So the language actually demonstrates the negotiation that is occurring, because the private plans are negotiating, and the private plans all hire the big companies that we talked about earlier, who actually are controlling access to, population that is much larger than the entirety of the Medicare population. So there's a lot of competition that goes on. There's a lot of negotiation. Read the trustees report. Every year, the Medicare trustees put out a report. They put out a table in the report that shows the average rebate amount. And the average rebates have been going up significantly over time. And it's only, rebates are paid only on the brand side, as noted by the trustees, typically not on the generic side. Read the CBO reports, read the administration reports about the competition and negotiation that's taking place. I mean, I think arguing that there's no negotiation is just missing the essence of the program. Read the CBO score that says that repealing the provision would not yield appreciable savings unless the government was going to restrict access to medicines, because there's already such effective negotiation taking place in the program. So the evidence is there to see, pretty much everywhere from a lot of independent sources.
Other questions? Comments?
I was just going to say, I would defer to Dr. Ganzen here, that the issue of Medicare negotiation, there's something to be a negotiation. There needs to be some sort of symmetry between the market power of the buyer and the seller. If Medicare, which represents the entire elderly population of the United States, negotiates, quote unquote, with the pharmaceutical industry, it effectively becomes a monopsony situation in which the buyer has all the power and can effectively dictate the price at which the drug will be sold, because if Medicare in the end doesn't agree to buy the drug or only agrees to buy it at a given price, there's essentially no recourse for a given pharmaceutical company. And in that situation, what one does not have is negotiation. One essentially has a dictation of what a price will be, and the very likely outcome would be prices below the socially desirable level at which R&D and a viable pharmaceutical industry could actually exist. So from that standpoint, it makes a lot of sense to me that Medicare ought not to be negotiating prices.
Okay, so underlying a lot of this discussion is something that's been published in several places. I recommend you look at an article of the BMJ called Foreign Free Riders, which addresses the trade association's multi-year campaign to argue that European countries are free riders on Americans because Americans are paying for all the innovation and European prices are lower, and therefore American prices have to be high. So if you want to know why your drug prices are high, just look at the French and the Swedes and the Italians and the English, and you will see why. So this article analyzes reports, both industry reports and government reports, and finds that at European prices, pharmaceutical companies are covering all of their R&D costs and operating costs and making a modest profit. And at American prices, they're making a much larger profit. So it's not a matter of a cross-subsidization and free rider situation. It's a matter of simply charging a lot when companies can in a country that allows that to happen. The other related point in terms of your comment just now is to do a little math. So if pharmaceutical companies devote about 15, 16, 17% of gross revenues from sales to R&D, according to the National Science Foundation annual surveys on research by industries, about 18% of that goes into basic research to discover new medicines. So that takes the percent down to about 3.5%. And then about 40% of all of the corporate gross costs are subsidized in various ways by taxpayers through tax credits and tax deductions.
And so you get down to about 2% of total revenues going to corporate R&D net of taxpayer subsidies.
Handing it to me for some reason that I can't say. Yeah, first, I'm delighted to know that everybody's reading everything that Pharma says. And so apparently I didn't know that. But I haven't seen this report, so I have no idea what that's about. But in any event, there's a couple of things that I will say. I think that throughout a lot of this discussion, there's been sort of a strain that okay, well, the R&D that pharma companies do, it's not very hard, it's not very good, it's not very expensive. And it really, it sort of makes the case this is actually pretty easy, what's the problem, and so forth. So, a couple of thoughts occur to me. I thought, and I don't want to put words in your mouth, Dr. Danzen, but I thought that, Dr. Danzen's discussion of the challenges that biosimilars face because they have to do a much pared down set of trials versus the innovator, and that being so costly and difficult, suggests, well, if that's costly and difficult, what the innovator is doing is a heck of a lot more difficult. And a lot more costly. Consider it, the biosimilar company knows a whole lot going in. They know that there's a medicine that works, that can get FDA approval. And as I mentioned earlier, if it's so easy, why do we have only 1 out of 8 drugs entering clinical trials after all the preclinical work being done that actually comes out as an approved medicine? As I mentioned, we had, I don't have the numbers in front of me, but Alzheimer's and lung cancer and so forth, just a tremendous number of failures. And it's because it really is difficult. It's difficult science. There isn't, sort of an engineering solution to this problem. And there's an enormous contribution made along the way. Over the years, there have been various efforts by folks in DC to get NIH to impose more conditions when it has any involvement in a drug. And NIH directors in administrations from both parties refused to do it because they recognized that that would actually significantly limit their opportunity to work with industry and to go from sort of a target that has been validated to a commercialized drug, which takes often a decade and failure after failure after failure. So I think that it's important to recognize that there actually is sort of an extraordinary research enterprise that's needed if we want to make progress. Beyond what we've already achieved.
We have just a couple minutes left.
I just have one quick question. So this is healthcare ethics and law, and we talked a lot today about research. And one of the things that I really do is look at translating the research into policy that we use. And the overwhelming question that I had today after listening to everyone present was, if we talk about things being ethical, how ethical is it for us to really continue to have these types of discussions without the people who are most impacted by the high drug prices actually represented or able to be a part of the decision making? Because if we look at the policymakers and the lawmakers, they are not impacted at all. Most people in this room are not impacted by the high prices of the drugs. So when I think about the ethical questions, when are we going to look at that and bring those individuals into the discussion? Because when they brought up the rural individuals, that was very valid, and I thought what you said was excellent on we need to have someone bringing that as an argument to the forefront. But if we look at what's going on in politics right now, the only thing that's being discussed regarding healthcare is can we repeal affordable care, and not what can we do about some of the issues that the people who are suffering are really being impacted by. So that was it.
Thank you, Dr. Moore. That's a great way to any comments from the panelists for just a few seconds about that, or should we just say thank you for this?
Well, I thought the fact that you had April present those cases was at least a partial attempt to bring the voice and pain and complexity of patients. But I agree, we should actually have those people in the room just for that.
Thank you. Let's thank our panelists for their topic today.
Before you depart, I have just a few final closing remarks, if I could keep your attention for just a moment. First of all, a conference like this does not happen just at a whim. It takes hours and hours and hours of planning and preparation. And I just would be remiss if I didn't recognize Dr. Lori Bateman. Lori, would you please stand? Dr. Bateman has really been the energy behind the HEAL Institute for a number of years and has made sure that this conference has come off without a hitch, and you did a great job. I also want to thank Elena Andrews, who is the Dean's Assistant for the McWhorter School of Pharmacy. She is the lady that you saw at registration. Please thank her as you're exiting. I also want to remind you that physicians, there is a goldenrod assessment form in your packet that we need to receive from you.
Actually, everyone, they want everyone to
Oh,
fill
they
it out.
want everyone,
They can,
not
yeah.
just
So,
not
thank
just
you.
physicians, okay. And then there's a green assessment form for the facilities and so forth that we'd like to collect. And for those of you who do intend to collect continuing education credits, we need your form before you leave today. We cannot accept it after the fact, so we actually have to receive it before you leave. With that, we will bid you farewell and thank you for your participation.
Thank you.
Someone's happier than you. No one's happier than you.